of all the diseases you should know diabetes. I'm not one to tell you to go learn all these laundry list of diseases, but you do need to know your diabetes. So let's talk about it. Definition: diabetes is an error of glucose metabolism. You don't metabolize your glucose well. That's what diabetes is. You cannot metabolize glucose for whatever reason. Sometimes it's a lack of insulin. Sometimes the cells become resistant to insulin. For whatever reason, you cannot metabolize glucose. Now, the problem with glucose is it's your primary fuel source. So diabetics get into trouble because they can't metabolize or use the primary fuel source. And without that, cells die. And that's why it's very bad. Now, don't confuse it with diabetes insipidus, because diabetes insipidus is a totally different disease. Diabetes insipidus is not a type of diabetes mellitus. It's a totally different disease. Diabetes, in the parenthesis, I want you to put diabetes insipidus is polyuria, polydipsia, leading to dehydration. Due to low ADH. Due to low ADH. So when you get a question about diabetes insipidus, and they want to know what you see, what do you see? Polyuria, polydipsia, and dehydration. Which looks a lot like diabetes mellitus, doesn't it? Because it has polyuria, polydipsia, and dehydration. So they look alike even though they're not the same thing. That's why they share the same first name, diabetes. So if you're sitting there and you can't remember what diabetes insipidus is, what's the best way to remember?
Dehydrated.
It's like diabetes mellitus, only just with the fluids. It's just the fluid part of diabetes mellitus. You don't get the glucose part. You just get the fluid part. And it's due to a low ADH. So what they'll ask you about diabetes insipidus is, a lot of times with diabetes insipidus, what they would ask you is, do you have a low urine output or a high urine output? And what you should say is, diabetes insipidus, it's not diabetes, but it's like diabetes mellitus, and diabetes mellitus has a high urine output, so diabetes insipidus has a high urine output. Do you see how I want you to remember it? Now, what is the opposite of diabetes insipidus? What's the opposite syndrome of diabetes insipidus called? SIADH. So here's what I do. I don't memorize SIADH. And I don't memorize diabetes insipidus. Why? But I get the questions right. How can you get the questions right on SIADH and diabetes insipidus and not memorize them? Everybody knows that diabetes mellitus has what? Polyuria and polydipsia, right? You should know that. So therefore, diabetes insipidus has what? Polyuria and polydipsia. So SIADH is the opposite. So instead of polyuria, they have low urine output, oliguria, and they are not thirsty because they're retaining water. Do you see that? So if they said to you, who gains weight? Diabetes insipidus, diabetes, who gains weight suddenly? Diabetes insipidus, diabetes mellitus, SIADH. SIADH. Why? Because diabetes insipidus and diabetes mellitus lose water. Right? And when you lose water, you lose weight. SIADH is the opposite. So who would have a urine output of 200 milliliters per hour for 3 hours straight and a normal blood glucose? Who would have diabetes insipidus? Who would have an output of 200 milliliters an hour for 3 hours in a row with a glucose of 280? Diabetes mellitus. Everybody says mellitus. I just am from the East Coast, so I say mellitus. Who has 10 cc's of urine out in 3 hours and a normal blood glucose? SiADH. Do you see how I'm saying? I want you to memorize that because boards does test DI and SiADH regarding urine output. So the two diabetes look alike urine output wise. The SiADH looks opposite the two diabetes urine output wise. What's the relationship between amount of urine and specific gravity of urine? What's the relationship?
Opposite.
It's inverse or opposite, meaning the less the urine out, the higher the specific gravity. The more urine out, the... So what specific gravities would SiADH have? SiADH is opposite the diabetes. The diabetes, do they have more urine or less urine? Diabetes. They have more. SiADH would have less. So if the urine volume is going down, the specific gravity goes up. So it would have a high specific gravity. Whereas diabetes insipidus, well, that would have what kind of a urine output? High, because the two diabetes have high urine output. So if the urine output is high, the specific gravity is low. So do you see how you're going to do this? And if you know the specific gravities and the urine volumes with the SiADH and the DI, you're ready to go with those two diseases. That's all they're going to test. So who would have the nursing diagnosis, fluid volume, of SiADH, DI, and DM? Which would have fluid volume deficit? Now think it through. Fluid volume deficit would be, what would you be doing with your output if you ended up with low fluid in your body, high output, and those would be what? DM and DI. Who would have fluid volume excess? SiADH. Do you see how I want you to think it through? Okay. I always find if you link things with other things you know, it's a lot easier to remember them than just remember them separately. Okay, let's dive now into, let's quit talking about the pituitary. Let's talk about diabetes mellitus directly. The types, type 1 versus type 2. You have to know these. They will expect you to know the differences between type 1 and type 2. Type 1 has 3 names. Insulin dependent, that's the I. Insulin dependent. J is juvenile onset. And K is ketosis prone. Ketosis prone. Ketosis prone. Now, one of those 3 will not be used after April 1. Which name will not be used after April 1? Juvenile onset. Okay, type 2s. The names are all of those. So instead of insulin dependent, it is non-insulin dependent. Instead of ketosis prone, it is non-ketosis prone. And instead of juvenile, it is adult. Which of those 3 will not be used after April 1? Adult onset. So you'll actually have to memorize less after April 1. C, the signs and symptoms. You must know the 3 P's. Polyuria, polydipsia, and polyphagia. P-H-A-G-I-A. P-H-A-G-I-A. Polyphagia. What does polyphagia mean? What's it mean? I can't hear it.
Thirsty.
Thirsty is polydipsia. What's polyphagia? Increased appetite. But technically, no. Polyphagia does not mean increased appetite. Although we use it to mean that, what does polyphagia actually mean? Increased swallowing. Now, if you eat a lot, what are you doing? Increasing your swallowing. But I want you to understand that that's not, when they say polyphagia, they are not always talking about eating a lot. For example, would polyphagia be a sign of increased bleeding after a tonsillectomy? Yes. And they're not talking about eating a lot, they're talking about swallowing a lot. See, so you understand, polyphagia technically means what? Swallowing a lot. In the context of diabetes, it's talking about eating a lot. The polyphagia only means eating a lot in this single context. Everywhere else, polyphagia means frequent swallowing. Okay? Treatment. If you don't treat type 1s, they could die. D-I-E. D for diet, I for insulin, and E for exercise. You treat diabetic type 1s with diet, insulin, and exercise. Of the three, which one is the most important treatment modality? Insulin. By far and away, insulin is the most important. Which one is the least important of the three? Nope. Diet. We do not mess around with type 1's diets anymore. We pretty much let them eat generally what they want. They count their carbs, they do their AccuCheck, and they give themselves the insulin accordingly. We don't restrict their diets like we used to. Now, we do tell them to lay off a bunch of refined carbohydrates, like, pure sugars. But they can even eat those nowadays, as long as they count their carbs and give themselves injections of insulin, according to their AccuChecks. However, the type 2s are different. Type 2s, if you don't treat them, they end up DOA. That doesn't mean dead on arrival. What that means is D for diet, O for oral hypoglycemic, which is the pill, and A stands for activity. Okay, of those three, which one for a type 2 is the most important treatment modality? Diet. So what is the least important for a type 1 is the most important for a type 2. It's a huge difference. In fact, most physicians would like type 2 diabetes to be controlled with diet alone. They would really, really like that. I don't know if anybody watches Biggest Loser ever, and they'll say, I had diabetes and I don't have diabetes anymore. No, you still have diabetes. You're just controlling it because you're losing weight. Is anybody watching the current season? I'm not really watching. I just watch it every so often. There's a girl on there, and she's wearing an insulin pump. You see it's like taped here, but they don't show it a lot, but she's wearing an insulin pump. And she's still over 200 and some pounds. It'll be interesting when she gets down. Do we not see that anymore? Because probably we won't. We'll probably won't see that pump there anymore. But she is a type 1, so it may not work. But it'll be interesting. A lot of people, diabetes can be controlled with just diet alone, particularly type 2s. Okay, turn the page and let's talk about diet, insulin, and exercise more in depth. When we talk about diet, who are we talking about primarily? Which type? Type 2s. We're talking about type 2s. Letter A, it is a calorie restriction. The primary dietary modification we make with type 2s in their diet is to restrict their calories. That's the primary thing we do. Hence, you get things like the 1,200 calorie ADA diet, the 1,800 calorie, the 1,600 calorie. So it tells you that calories are important because that's how it's named. So a calorie restriction is the most important part of a diabetic diet. Letter B, they need 6 small feedings a day. So if they have 1,800 calories, how do you split that 1,800 calories? Into 6 separate feedings. Because what does that do? Yeah, it keeps it level so you don't get these big peaks. Because if you chalk that all in 3 meals, you're going to have these 3 big peaks. But if you do it in 6, it's going to be more level. And therefore the blood glucose is going to stay more normoglycemic. which one would be best? What if you got a question like this? You have a type 2 diabetic. What is the best dietary action to take? A, restrict their calories to an appropriate level. B, divide their food into 6 feedings a day. Okay, now, don't jump to conclusions because you have to understand this is a best question, right? And in a best question, how many do you get to do? 1. And if you say you're going to do one, you're not going to do the other. In fact, you're going to do the opposite of the other. So if you pick A, all right, they're going to follow their calorie restriction. And it's 1,600 calories, all right? If you say, I am going to give them 1,600 calories a day, what does that mean you're not going to do? They're going to get it what? In 3, just going to get 3 meals a day, and they're going to get 1,600 calories in 3 meals because we're not going to split it in 6. That's what you're saying if you pick calorie restriction as your best answer. Okay, let's see what you're saying if you pick 6, split it into 6 meals, 6 feedings. Okay, if you pick that, you're saying what? I'm going to split it into 6 feedings, but what? But they can eat as many calories as they want. So what would be better for a diabetic? To get 6 feedings a day, eating as many calories as they want, or to eat 3 meals a day following their calorie restriction? What would be better?
Restrict calories.
So what is the best answer? Calorie restriction. Do you see what I'm saying? And you have to be, because usually when you shout out an answer or you jump to an answer without the thinking, you tend to go to the wrong one. So think it through. Do you see what I'm saying? Are you understanding this process that I'm teaching you about how to deal with best questions? How do you deal with a best question? Narrow it down to how many? 2. If you can narrow it down to 1, what should you do? Pick it. Okay? But everybody tells me they can only narrow it down to 2, and then they don't know what to do. Well, if you narrow it down to 2, then what do you say? I will do this one, but not do that one. And then flip it around. I'll do that one without doing this one. And one of those you'll like better. So pick the answer that's you're going to do in the one you like better. Question?
Would that still be the same if you're talking to a patient who's like 400 pounds and is used to, let's say their baseline is 4,000 calories a day.
Okay.
But they have been real good at splitting those up into 6 meals.
Okay.
Would that still be accurate to say they need to slash those instantly into 1,800 calories?
Okay, write the question.
You have
Are you talking about a question, or are you talking about what do you do in real life?
I'm saying, yeah, for a board's question, if you have,
Okay.
in
Write the question, and then I'll give you the answer. But I need to know how you're going to phrase the question here.
what would be more preferable for a 400-pound patient
400 pound
whose baseline is 4,000 calories
a day.
to help control their type 2 diabetes?
Okay.
What is the best answer?
Okay, what's the best answer? Now, if the answers are reduce them to 1,200 calories versus teach them to separate the calories into 6 meals. And they're talking about starting, I might seriously question the 1,200 calorie because it's such a big, huge drop initially. But the best would be to drop to 1,200 calories. The best answer still is 1,200 calories. But I probably wouldn't do it first. Remember yesterday I said there's a big difference between a first and a best. So if they said to me, what would you do first? I'm not dropping him to 1,200 calories first. I'm going to teach him how to separate it. Then I'm going to start whittling down each time to get him there. Does that make sense?
Yeah.
So I think in your case, the 6 meals would be the first thing you might do in that scenario. Okay. But see, the only time that works is when you wrote that scenario specifically that way, which boards doesn't get that picky. They go more general because they want to know, if you miss it, did you not know what to do generally? Then they can say you shouldn't pass. Do you see what I'm saying? Because if you didn't know what to do in some specific unusual occurrence, if you miss it, they can't really fault you because nobody else knew it. Does that make sense? Okay. The problem is in school, you guys are given all these bizarre questions that are tricky, and they add this in, and they say, aha, but you forgot about that. So you miss it, and you get socialized into thinking that's the way. But on boards, they don't do that. I mean, boards is, but if you have to trust that boards is fair, and it really is. They're well-tested questions. Okay, does that answer the question?
Yeah.
Okay. Let's see. Insulin. Insulin acts to do what to the blood glucose? What does insulin do to the glucose level in your blood? Lower. It lowers the blood. That's good to hear. I went to a school one time and asked that question, and everybody said, raise. And I thought, oh boy, I have my work cut out for me here. So insulin acts to lower your blood glucose. Now there are 4 types of insulin you need to know. Now there are many, many types of insulin, but there are 4 that you really need to know for boards. You don't need to know Exubera, Byetta, Apidra. You do need to know R, N, Lispro, Humalog, and Lantus Glargine. So let's talk about these 4. Regular insulins, the ones with the big bold R on the bottle. It has actually lots of different names. It could be Humulin R, Ileton R, Novolin R. The name is irrelevant. What is important is that big bold letter R. That means it is regular. Its onset is in 1 hour. Its peak is in 2 hours. Its duration is 3 hours. It is clear. It's clear in the bottle. It's clear. So it's a solution. So it can be IV dripped. This is the insulin you use when you use IV drip insulin. Now, Hesse will call this an intermediate acting insulin. The product insert that comes with the bottle from the manufacturer that the FDA approves says it is a rapid, short-acting insulin. So I don't know why Hesse insists on changing the FDA's classification. But if you learned that it was intermediate, it is still considered by the FDA and the product insert as a short, rapid-acting insulin. Why do you think a lot of people are starting to talk about regular not as a short, rapid, but as an intermediate?
Because they use Lispro.
Exactly. Because 5 years ago, 10 years ago, we didn't have Lispro. And the fastest one was regular. Now we have Lispro that works in 1/4 the time that regular does. And it's kind of silly to talk about Lispro as being the same time phase as R, isn't it? But I really believe that if boards asked you, is R short, rapid, or intermediate, you should go with what the FDA and the product insert says, not what Hesse says. Do you see what I'm saying? Or Hesse's books, anything from Elsevier will say it's intermediate. Okay. All right. NPH insulin, N, is truly an intermediate acting insulin. It's a true intermediate acting insulin. Its onset is in 6 hours. Its peak is 8 to 10 hours. And its duration is 12 hours. It is cloudy. It is a suspension, as all cloudy things are. They are not solutions. Cloudy things are suspensions. Clear are solutions. Cloudy are suspensions. And the bad thing about a suspension is a suspension precipitates. meaning the particles fall to the bottom over time. So you cannot give this drug IV drip, or you will overdose them and their brain will die. But there's a general rule: never put anything cloudy in an IV bag, right? When I have students clinically, I'll teach them something that can help them a little bit. When they pull out a bottle of R from the shelf or the refrigerator, I'll say, "What does that R mean?" And they will say, "Regular." And I will tell them, "No, it doesn't." Whereupon they start to panic. And I say, "Wait a minute, I'm just trying to teach you something here, so don't panic. Yes, it does mean regular, but I'm trying to tell you that R really means two other things. That R stands for rapid and run. Rapid meaning it's what? Fast acting, and run means run at IV. They will pull out the N bottle, and what's the first question I ask them? What does the N stand for? And they'll say NPH, and I'll say no. And they'll start to panic, and I'll say, "Wait a minute, I'm just trying to teach you something here." That N actually stands for two other things. Do you know what that N stands for? Not so fast. Not so fast, which means it's what? Intermediate. And not in the bag, which means you never put it where? IV. Because I want my students, the minute they pull that N off the shelf, what do they say? It says a big N on it. And they say what? Not so fast and not in the bag. So they will never what? Draw it up and stick it in an IV bag, because they know N is not in the bag insulin. Actually, my students will forget that it's NPH. They'll call it not in the bag and not so fast insulin. And R, they'll call it rapid and run insulin. And I think that's kind of functional. It kind of works. All right, now, let's talk about the onsets, the peaks, and durations of these famous insulins. Look at the pattern. What do you see as you read across the page? 1, 2, 4, 6, 8, 10, 12. 1, 2, 4, 6, 8, 10, 12. What are you counting on?
You said 3, you took 4.
Did I mess up something? What did I say? Okay, the regular onset is, 1. Peak is 2. Duration is 4. I'm sorry, did I say 3? I was thinking Lispro. I'm sorry. So it's 1, 2, 4, 6, 8, 10, 12. Do you hear the even numbers? So what's 1, 2, 4? Regular. What's 6, 8, 10, 12? N. So just remember 1, 2, 4, 6, 8, 10, 12. 1, 2, 4, 6, 8, 10, 12. Which of those will they test the most commonly? Of those, no, they test N and regular equally. The peaks. They test the peaks. So what do you really have to remember? 2 and 8 to 10. The way they'll test it. In fact, how do they test it? You tell me how they test it. What does the question read like?
Keep your time, blood sugar, and
You gave 30 units of N at 7 in the morning. Then what do they ask? When would you check for hypoglycemia? Which means low sugar. Well, the low sugar is going to be when the med's at its peak. So that's the way they ask for the peak without ever asking about the peak. They ask about hypoglycemia, which is the peak. So if you gave N at 7, when would you check for hypoglycemia, which is the peak? N. You gave N at 3 p.m. to 5 p.m. Somewhere between 3 and 5 p.m. Or late afternoon, they would say. See how that works? Take the peak, add it to the time they gave it. That's when you check for the hypoglycemia or the peak. Humalog, Lispro, the world's fastest acting insulin. Its onset is in 15 minutes. It peaks in 30 minutes, and its duration is 3 hours. 1533. So when do you give this insulin? As they begin to eat. So you give it with meals, not AC. What does AC mean? PC means after meals, post, PC. A means ante or before. So AC means before the meal. Do you give Lispro AC? Before the meal? No. You give it with the meal. So be real careful with your words there. The word before is wrong. The word with is correct. I tell my students, if you're not interrupting their meal to give them their Lispro, you're doing it wrong. You don't give it when the trays arrive on the unit, because it may take another 15 minutes till they get passed. By then, the Lispro is already working. And then you can't arouse them to eat, because it's peaking. All right. Lantus. Lantus is a long-acting insulin. It is called Glargine, Glargine. And nowadays they're most likely to call it Glargine rather than Lantus. Glargine. It's a long-acting insulin. It is so slowly absorbed, it has no essential peak. It is so slowly absorbed, it has no essential peak. What that means is this one has low risk for hypoglycemia. Little to no risk of hypoglycemia. So this drug is the only insulin you can safely give at bedtime, because they will not go hypoglycemic during the night with this one. The others you cannot give at bedtime. The only time you can give the others at bedtime, well, you never give N at bedtime. But the only time you can give R or Lispro at bedtime is if what? Your Accucheck said they were sky high, then you can give it. But you wouldn't routinely give Lispro or regular at bedtime. You can give Glargine routinely at bedtime regardless of the glucose. Duration is 12 to 24 hours. So those are the main insulins and what they're going to test. Letter B, check the expiration dates on your insulin. Please, that's important. What action by the nurse invalidates the manufacturer's expiration date? What action by the nurse invalidates the manufacturer's expiration date on the bottle? What's that? Opening it. Opening it does. The minute you open a vial of insulin, what is now no longer valid? So the manufacturer's expiration date is only good as long as it's still closed and sealed and unopened. Once you open it, now the manufacturer's date is irrelevant. What becomes the new expiration date is 30 days after that. And make sure you write on the bottle that date, and make sure you write EXP or opened. Why do you need to write opened and then the date, or EXP and then the date? Why can you not just write the date on it? Well, if I come along and I see a date, I don't know if that's when you opened it, and I don't know if that's when it expires. So when in doubt, I will throw it out, and I'll throw that insulin away. So you put EXP and a date, or opened and a date. Okay, make sure you're clear. Refrigeration is optional, meaning you don't have to refrigerate insulin in the institution. But you do have to teach patients to refrigerate their insulin at home. Now, in the hospital, the insulin that probably should be refrigerated are the unopened vials. However, once a nurse opens a vial, two things happen. Number one, the manufacturer's expiration date is no good anymore, and you got to write a new expiration date on it. And number two, it now does not have to be refrigerated in the hospital. So if they said to you, what's the most important thing, the best thing to do when you are dealing with insulin in the hospital? In your between, check the expiration date before you give it and refrigerate it when not using it. What's the best answer? Well, you'd have to figure that out. If you pick check the expiration date before you give it, you're not going to do the other one, which was what? So you're going to check the expiration dates but leave it out of the refrigerator. Or you will what? Refrigerate it and not check any expiration dates and maybe give expired insulin. So would it be better to give cold expired insulin or warm non-expired insulin? Warm non-expired. Do you see what I'm saying? So the answer, best answer is expiration date. Okay, exercise potentiates insulin, which means does the same thing as. Potentiates means does the same thing as. I want you guys to think of insulin, I want you to think of exercise as another shot of insulin. Whenever the question says, and he exercised, what do I want you to replace those words with? And he got another shot of insulin. She's going to play soccer this afternoon. Replace that with what? And she's going to get another shot of insulin this afternoon. He has gym class this morning. He's going to get an extra shot of insulin this morning. Do you see what I'm saying? So if that's the case, if you have more exercise, what's that mean? More shots of insulin, you actually need less insulin. But if you have less exercise, you need more insulin because exercise is like an extra shot of insulin. So if a diabetic is going to play soccer in the afternoon, what should the school nurse do? He's going to get an extra shot of insulin, so he better what? What should he take to the game? Rapidly metabolizable carbohydrates, right? As a snack before the meal, before the game, and during the game. Okay, sick days. Diabetics get sick for other reasons besides their diabetes, like they get the flu, they get diarrhea, they get otitis media. What do they do when they're sick? Well, when the diabetic is sick, their glucose is going to go up. It'll never go down. It always goes up. So they have to take their insulin, even though they're not eating. Because a diabetic, let's say a diabetic gets the GI flu and he is nauseated and he's throwing up and he's not eating. What's he going to say? Well, I'm not eating, so I shouldn't take my... Do you hear about that? Hey, but that's wrong. Your glucose is going to go up even if you're NPO, when you're under the stress of illness. So they take their insulin, even though they're not eating. Number 2, take sips of water because they're going to get dehydrated. Diabetics get dehydrated. It probably would be worth your while to remember that a sick diabetic has 2 problems: hyperglycemia and dehydration. Any sick diabetic is going to have those 2 problems. So just count on it. Hyperglycemia and dehydration. Always. Every sick diabetic will have those problems. And then stay as active as possible. Why? It helps lower the glucose. And they're a sick diabetic, even if they're not eating, their sugar's going to go which direction? Up. All right. Now before lunch, we'll see what we're going to go to lunch at noon. Before lunch, I want to cover the complications of diabetes, and we'll see where we're at after that. There are 3 acute complications of diabetes and a boatload of chronics. Let's talk about the acute complications first. You should never go to boards not knowing this, because they test this all the time. You have to know your signs and symptoms and treatment of the 3 acute complications of diabetes mellitus. The first one is low blood glucose in a type 1 or a type 2. It's called insulin shock, insulin reaction, or hypoglycemic shock, or hypoglycemia. It has bunches of names. It means their sugar is low. Their glucose is low. Now, what in the world would ever cause a diabetic's glucose to go low? That's a good question. Because when a diabetic isn't sick, but has diabetes, what does their sugar run? High or low? High. And when they get sick, it runs even higher. So if you're well, it's high, and if you're sick, it's even higher. So how in the world could it ever go low? Great question. Well, here are the causes. Not enough food, too much insulin or medication, and too much exercise. Wouldn't those all make the sugar go down? However, one of them is the primary cause. Which one is the primary cause? Too much medication. In fact, I would say that it is impossible for a diabetic to have a low glucose without being over-medicated. So over-medication is the number one, almost sole cause of hypoglycemia in diabetics. The danger here is brain damage. And the bad thing about brain damage, it's permanent. So this is no small thing. You can destroy people's lives as a nurse by over-medicating them with insulin. You can take an alert-oriented person like me and cause me to be in a persistent vegetative state in a nursing home for the rest of my life because you made one mistake with insulin. Okay? What were the signs and symptoms? The signs and symptoms you must know because boards will want to see if you can pick up hypoglycemia just by looking at the patient. Now, the easiest way I know to memorize the signs and symptoms of hypoglycemia are drunk in shock. Drunk in shock. Now, what am I talking about on this one? Here's what I'm saying. Most of you guys in here know what drunk people look like. Okay? So what does a drunk person look like? Describe it for me.
Staggering.
Staggering gait. Slurred speech. Judgment. Poor judgment. Impaired judgment. Reaction time. Delayed. Emotions. Drunk person's emotions. Talk to me. Okay, but they won't say all over the place. They'll use a fancy word called labile. L-A-B-I-L-E, which means all over the place. Laugh, cry, laugh, cry. Could they be a little obnoxious and belligerent? A little bit loud? Decreased social inhibition? Those are all signs of hypoglycemia. So anything that would characterize a drunk person will also characterize a hypoglycemic person because both people are having cerebral cortical compromise. Now, the other part of the picture is shock. They also look like they are in shock, which is the vasomotor part of the syndrome. So what does a person in shock look like? Low blood pressure, tachycardia, tachypnea. What else? Skin, cold, pale, clammy. Could it be mottled in the extremities? Patchy, yeah. So, what I want you to do is I'm assuming that everybody in here knows what drunk people look like. And I'm assuming you know what shock looks like. So I'm saying to get hypoglycemia, all you do is add those two. Drunk plus shock. So I don't want you to memorize any new list. Just derive the new one from two old ones you already knew. So drunk is drunk, shock is shock. Add them together, you get hypoglycemia. So when you get a select all that apply for hypoglycemia, what do you do?
Look for the drunk and the
Go through and
shock.
select everything that applies to whom? A drunk, and then select everything that applies to a person in shock. And I'm not talking about anaphylactic or neurogenic or septic shock. I'm talking about shock, generic, basic, oh my goodness, I'm bleeding to death shock. All right? Well, what do you do for it? Number one, administer rapidly metabolizable carbohydrate, i.e. sugars. If boards says, if you're looking for the word sugar and it's not there, they probably are saying rapidly metabolizable carbohydrate, because that is synonymous with the word sugar. Now, what would be some examples of a rapidly metabolizable carbohydrate that you could give in a hypoglycemic situation? Any juice. There's nothing magical about orange. It could be apple, grape, pineapple, guava, pomegranate, grape. What else besides fruit juices? Now, what? Low-calorie, sugar-free pop? No, regular pop. Which a lot of times they go, oh, wow, cool. I get to have pop. What else? Chewed up candy. Let them chew it up. What else? What? Well, no, crackers don't have enough sugar. Milk is great because it has lactose, so it's got the sugar. Honey, icing, jam, jelly. Those are great, rapidly metabolizable carbohydrates. Okay, however, boards really want you not to give just a sugar. They want you to give an ideal combination of foods, which is the next point. What is the ideal combination of foods? You want a sugar plus a starch or protein. That's where the crackers come from. The crackers are the starch, the orange juice is the sugar. Orange juice and crackers, good job. Because you got the sugar and you got the starch. Or you could say apple juice and a slice of turkey. Because what would that be? Sugar plus protein. Which is why the milk is so fantastic. Because when you drink milk, what are you getting? Sugar and protein, which is perfect. But you use skim milk because you don't want them to burn fats for the ketones, right? So it's 1/2 cup skim milk. Fantastic answer for hypoglycemia. 1/2 cup skim milk. What's a bad answer? What's a bad combination of foods to give them? What would be a bad combination of foods to give them? Such as? No, not carbs. No. Carbs was too broad.
Like candy with cola.
Yes. Giving them a bottle of pop and a bunch of candy to chew on. You know, 1 sugar is good, 2 sugars are bad. So give them 1 sugar and 1 starch, 1 sugar and 1 protein. So what do you think about 5 packs of sugar emptied into a glass of orange juice? Not the way to go. It's not the way to go. Okay. What if they're unconscious? What do you give them? Glycogen. Or glucagon, actually. Glucagon. Which gives you mobilizes the glycogen. Glucagon IM. A shot, an intramuscular injection of glucagon. What else can you give them? By another route. Dextrose per IV. But D5 is not going to do it. It's going to be D10, D50. Because D5, a whole liter at D5 only gives you 300 calories.
So D10?
Yeah, you need some D10, D50. You need some real powerful dextrose. Not just D5 won't do it. So, what will determine which one you give? The D50 IV or the glucagon IM? Because they're both appropriate. So what will determine that? The setting. The setting will. If you are talking to the mom and dad over the phone, and they're asking what they do with their unconscious hypoglycemic diabetic kid, what do you tell them to give? The IM glucagon that they should have in the refrigerator. They should all have one in there. What do you not tell them to do? Start an IV of D50. However, if they tell you it's in the emergency department and you got a severely unconscious hypoglycemic client with a glucose of 7, what do you give them? IV of dextrose. But good luck starting the IV. Because they look like a what? Drunk in shock. And what happens to peripheral vessels in shock? So good luck. You know. That's why I love saline locks and heparin locks. Intermittent venous access devices. Because if I need a lifeline in an emergency, it's going to be there. Because the hardest time to start an IV is a lifeline is in an emergency because they clamp down peripherally and you can't get a vessel, can't get a cannulation because it's vasoconstricted. That's one where you just aim for where the veins are supposed to be, you know, because you can't see anything. Alrighty. Number 2, high blood glucose in a type 1. It's called DKA. Diabetic ketoacidosis or diabetic coma. Have you heard of DKA? Mm-hmm. I hope you have. Who gets it? Only type 1s. What should have told you it was only type 1s? How should you have known it was only a type 1? That only type 1s get diabetic ketoacidosis? Because another name for type 1 is what? Ketosis prone. And type 2 is non-ketotic. So how can a non-ketotic have diabetic ketoacidosis? They can't. So only a ketosis-prone type 1 can have DKA. Well, what would cause their glucose to go high? Well, too much food, not enough medication, not enough exercise will make the glucose go way high. However, none of those are the number one cause of DKA. The number one cause of DKA is below. The number one cause of DKA is acute viral upper respiratory infections within the last 2 weeks. So what causes DKA? Number one cause of DKA. A type 1 gets what?
A viral?
The virus of the month club at school, right? And they get the upper respiratory viral pharyngitis that every kid in school has, right? And they recover from that within 3 to 5 days like everybody is. But after they recover initially, what starts happening? They start going downhill and getting more and more lethargic because this is called diabetic ketoacidotic coma, DKA. So they start going downhill. So that when they come in the ER and you check their blood glucose and it's 850 and they have the signs of DKA, what do you ask mom and dad? That was when the last time they ate.
Have they had a viral infection in the last 2 weeks?
Yes. Have they had a viral infection, upper respiratory, in the last 2 weeks? What will they almost always say? Yes. And what caused the glucose to go high was the stress of that illness that was not shut off. And they started to burn fats for fuel and they got into a negative situation. Well, what are the signs and symptoms of DKA? Turn the page. What are the signs and symptoms of DKA? I like it because they are DKA. You can get the signs and symptoms from the initials of the disease. So, D stands for dehydration. They look dehydrated. You should have known that, because what did I tell you sick diabetics always get? And a high sugar. And these people have a high sugar and they are dehydrated. Classic. The K stands for 3 things that start with the letter K. They have ketones. Now, just for fun, DKA. Tell me if this is a true statement. DKA, they will have ketones in their blood. They will have ketones in their blood. True. Okay. DKA. Everybody with ketones in their urine has DKA? No. So you can have ketones in your urine and not have DKA. But if you have ketones in your blood, you have DKA. So it's the ketones in the blood that confirms the diagnosis. The ketones in the urine, that doesn't typically mean that you have DKA. Okay, the second K is Kussmaul. They Kussmaul. What's that mean? Deep and rapid. They hyperventilate. Deep and rapid Kussmaul. And the third K is K. They have a high K, which means what? Potassium. Potassium. The A stands for three things that start with an A. They are acidotic. What kind of acidosis? Metabolic, and that fits with Mac Kussmaul, doesn't it? A, they have acetone breath. Acetone breath, which means they have a fruit odor to the breath. And it's not always a nice mango essence either. It can be a rather funky, fruity smell. And A, they have anorexia due to nausea. Anorexia, what's that mean?
They don't want to eat.
They don't want to eat. Why? Because they're nauseated. So if you said to me, Mark, what are the signs and symptoms of DKA? I'd say, well, let me think here now. D, dehydration. So they're what? Dry, mucous membranes, weak, thready, pulse, dry, skin, poor elasticity, headache. What would the skin be if you're dehydrated?
Tinting.
Poor elasticity. What else? Dry. What temperature? No. Water in your body performs the same function as water in your car. If you dehydrate your car, meaning spring a leak in your radiator, and you leak water out of your car and you dehydrate your car, what will happen to your engine? It'll overheat. So water is a coolant. So if you dehydrate, you overheat. Your skin will be what? Hot and flushed. Hot, flushed, dry. That's dehydration. See, I'm assuming you knew the dehydration signs. Maybe that was an assumption I shouldn't make. So DKA, first you check off all the dehydration signs, right? Then what do you check off? Ketones, Kussmaul, and K. Then you check off acidosis, acetone breath, and anorexia due to nausea. DKA. 1D, 3 Ks, 3 As. And those are the signs and symptoms of DKA. Well, what do you do for it? Well, they're dehydrated and their sugar's high. So what do you do for the dehydration? IV fluids. Low or fast rate? Fast rate. This one would be around 200 an hour. Some of the fastest rates you'll use are these ones. Burn is, of course, the fastest rates that you run in the first phase. But these ones are pretty high. And what do you put in the bag? The IV bag. To lower the sugar. Regular insulin, because you can run that. So you're going to get an IV with regular insulin run at about 200 an hour. That's pretty standard. And the main solution doesn't matter. It doesn't matter whether it's normal saline, 0.45, D5, 0.45, D5W. You're going, but their sugar's high. Why are they getting D5? What did I say about D5? 300 calories. So even if you run it at 200 an hour, they're only getting 60 calories an hour. That's nothing. You see what I'm saying? And anyhow, the D5 molecule is small, so it just goes right out. As soon as it gets in your bloodstream, it goes into the tissue. It doesn't even stay in your bloodstream to contribute to your glucose. If you guys have ever been taught to worry about the dextrose in the IV bag because of a diabetic, that's poor teaching, because that doesn't even stay in the veins. It goes into the tissue. The dextrose in the bag, if it's D5, will not create a hyperglycemia situation. Now D10 will, D50 will, but D5 will not. So don't worry about the dextrose in the bag. It's no big deal. We used to be all over that when I was in school. Oh, they're diabetic. Get the D5 out of there. Not real good practice anymore. Okay, number 3, low blood glucose. I told you the type 1 is the same as type 2. Number 4, high blood glucose in a type 2 is called HHNK, HHNC, and some places call it HHS or HHNS. Which one do you guys use? HHNK? Did anybody use HHS? HHNS? HHNC? It's all the same thing. Who gets this? Which type? Why should you have known that a type 2 gets this? What in the name tells you it's a type 2? Non-ketotic. And whenever you see the prefix non, you know it's a type 2. Type 2s are the ones that have the nons. Type 1 never has anything that has non in it. Now, how many of you in here, if you got a bunch of questions on HHNK, hyperosmolar, hyperglycemic, non-ketotic coma, on your test, would kind of get a little nervous? Simply because of the length of the name. Well, this is actually one of the easiest questions you can get because it is very simple to understand. Letter B, this is dehydration. That's all it is. Here's my point. How many of you in here, if I told you, you have a choice of taking 2 tests. One test is 20 questions over the causes, signs and symptoms, and treatment of HHNK. And the other test is over the causes, signs and symptoms, and treatment of dehydration. Would you have a preference? Which one would you rather take? No, but before I said anything, a half an hour ago, what would you have chosen? Dehydration, not HHNK. But what's the reality? It's the exact same test. So here's my point. Wherever you see the phrase hyperosmolar, hyperglycemic, non-ketotic coma, you can pull that out and plug in what word? Dehydration. Answer that question, you will get it right 100% of the time. So what would the skin look like in HHNK? Don't answer that. What would the skin look like in dehydration? Low water. Hot, flushed, dry. What would be the number 1 nursing diagnosis that you would see with HHNK? We'll refuse to answer that. What would be the number 1 nursing diagnosis you would see with dehydration? Fluid volume deficit would be your number 1 nursing diagnosis. What would be your number 1 nursing intervention or medical intervention for a client with HHNK? Well, I refuse to answer that. What would be the number 1 nursing or medical intervention in a patient who is dehydrated? Giving fluids. Do you see? What would be some outcomes you would want to see in a client with HHNK? Increased output. What's that? What? Coming what direction? Up. What's that? Moist mucous membranes. All the things that you would like to see if somebody were dehydrated. What would the outcome of your treatment want to be? You'd want to see them. So I guess what I'm saying is don't make HHNK hard. Make it easy. It's nothing more than dehydration. It's actually DKA without the K or the A. Because if you take DKA and you take the K out and the A out, what do you have left? Dehydration. That's HHNK. Why do HHNKers not get the Ks and the As and only the D? Because they don't burn fats, they don't make ketones. If you don't make ketones, you don't get ketones. If you don't get ketones, you don't get acid. If you don't get acid, you don't Kussmaul. If you don't get acid, you don't have the K shift that raises it. If you don't have the ketones, you don't have the acetone breath. And if you don't have that, your lining of your gut doesn't swell and make you nauseated. So what did I just rule off the DKA list? All of the what? Ks and all of the As, and the only thing I had left was the D. That's why HHNK is just the D. whereas DKA is the D, the K, the A's. Does that make sense? I want you to look at this. Okay. Therefore, which one is the use of insulin most essential in treating? HHNK or DKA? Which one is insulin the most essential in treating? Well, if I said HHNK and DKA, you would immediately change HHNK to what? Dehydration. And if I said, in what situation do you need to use insulin? DKA or dehydration? What would you say? DKA. So the answer is DKA. You don't have to use insulin with HHNK. All you have to do is rehydrate them because they are dehydrated. By the way, which one is more life-threatening? Which one has a higher mortality rate? More people die of? HHNK or DKA?
DKA?
No, actually, more die from HHNK. Which one, if a DKAer comes into the ER and an HHNK comes into the ER, who is higher priority? The DKAer. Which doesn't seem to make any sense. Because I just said, who has a higher mortality rate? HHNK, but who's a higher priority? DKA. Well, can someone explain that to me?
The HHNK, they come in later when they're...
They come in a lot later because they don't have the acidosis, the ketosis that makes people see symptoms. And so they get worse and worse and worse. So by the time they come, they're already bad. But a DKAer is acutely ill with all these symptoms that we can quickly treat with a simple rehydration with insulin. Do you see? Whereas the HHNKer will probably be treated with IVs, but probably is in such bad shape they're probably not going to make it anyhow. But you understand what I'm saying? Now, who would die first if we didn't treat them? HHNK or DKA? DKA. But we treat them so they actually have a lower mortality rate, even though it's more life-threatening. Does everybody get that? Okay. Long-term complications of diabetes are related to two problems. Oh, by the way, okay, B said this is dehydration. C says the signs and symptoms are like signs and symptoms of dehydration, and the treatment is rehydration. Did you get those blanks filled in? Good. Number 5, the long-term complications of diabetes are related to letter A, poor tissue perfusion, and B, peripheral neuropathy. Poor tissue perfusion and peripheral neuropathy. Now, what are some long-term complications? They are not DKA, HHNK, and hypoglycemia. Those are acute complications. I'm talking about renal failure, gangrene, stasis ulcers, blindness, impotence, heart disease, brain disease. So, if they ask you, diabetics have renal failure, what would this be due to? Well, it's one of two. Which two is it up? It's one of the two. Either what? Poor tissue perfusion or peripheral neuropathy. If it's renal failure, which one do you think it is? Poor tissue perfusion. If it's that they lost control of their bladder and they are now incontinent, what is that? Peripheral neuropathy. They can't feel it when they injure themselves. Peripheral neuropathy. They don't heal well once they injure themselves. Poor tissue perfusion. See, you're going to always blame it on either poor tissue perfusion or peripheral neuropathy, whichever one makes the most sense. It'll be pretty logical for you. Number 6, which lab test is the best indicator of long-term blood glucose control? The hemoglobin A1C. The HA1C. HA1C. The hemoglobin A1C. It's also called the glycosated hemoglobin. The glycosated hemoglobin. I've also heard it called the glycosylated hemoglobin. It's the same thing. Glycosylated hemoglobin, glycosated hemoglobin, hemoglobin A1C are all the same test. Now, what numbers do you want to see with the HA1C? You want it to be 6 and low. 6 and lower.
6 what?
Just 6. On boards, they never test units. So all you need to know is numbers, which is great. What hemoglobin A1C means you're out of control. 8 and above is out of control. So in the 6s and lower means in control. 8 and higher means out of control. So where's the problem? With a 7. So the question is, when they come in with a hemoglobin A1C of 7, what's the conclusion? Yeah, they're on the border. So what do they need? Some workup. They need some evaluation. They need brought in the hospital, checking out what's going on. They might have some infection somewhere. So a hemoglobin A1C of 7 means we need to check on you. 6 means you're good to go. 8 means you're out of control. 7 means maybe. So just so you understand what the implications of those numbers. You'll see on TV, I just saw an advertisement the other day. It said that a certain thing lowered the A1C 0.9, which actually is really almost the whole point, which could take you from out of control almost to control. So it doesn't sound like much of a change, but for an A1C, a 0.9 change is huge. All right, let's get is stuff here? Okay, let's get our blood sugars up. I feel bad because we're going to end up doing dumping syndrome right after lunch. That's not good. That's what happens.
When we did that one day when we we brought in our meals that day, we were doing anorexia that day.
Yeah, the anorexia.
All right, we'll start. Is anybody not here? You're all here? Okay, let's do drug toxicities on page 26. Bad news, you got to know your drug toxicities. Good news, you don't have to know them all. You just need to know what everybody else knows. And if anybody knows drug toxicities, they know these 5. Anything beyond these 5 is really nuts to know. It's not really need to know territory. You do need to know these 5, though. I would really suggest that this is a little bit of memory work, but it's a good payoff for it. Because you understand this is a test for nurse safety, and one of the biggest ways you can be unsafe is to not know drug toxic effects. You see how that could result in real patient harm. So that's an area they like to test is toxic reactions to drugs, drug toxicities. So let's talk about these 5. Lithium. Lithium, of course, is the famous anti-mania drug. It's used for bipolar, but it's not used for the depression. It's used for the mania. Its therapeutic level in the middle column there, you should write 0.6 to 1.2. Now the toxic level is greater than or equal to 2. Now immediately you should see that there is a gray area there where you're higher than 1.2 but under 2.0. Do you see that gray area? That is a gray area where no books agree on exactly what's going on with lithium at those levels. From 0.6 to 1.2, everyone agrees that it is therapeutic. Everyone agrees that 2 and over is toxic. But in between, you just pick your book and they're going to say different things. One of the things that you guys don't know about me, well, maybe you do know about me, that probably is good for you to know about me to help you understand why I say what I do and how I say what I do, is that for years I was a NCLEX RN item test writer. I wrote questions on the NCLEX. So the questions that were on there, I've written some of those questions. So I've been through the whole training protocol on how they want you to write questions for them. So when I tell you that questions are written this way, that's because I've been through the in-service education on it, and I've been trained as their item writer. In 2003, I think it was, maybe it was 2002, somewhere right around in there, the NCSBN made a rule that you cannot be an item writer and be a NCLEX reviewer at the same time. Which makes sense. You can't write the questions and then go teach people how to pass the test. It's not ethically correct. So at that time, I had to pick between writing questions and reviewing, and I picked reviewing, and so I stopped writing questions. And so I haven't written a question since 2003, roughly. But if they only change 5% every year, there's still loads of questions on there that I've written. Now, I say that to tell you that when I give you ranges, the ranges I give you may not be the ones you learned, but they are the ones that you use when you write questions. Do you see what I'm saying? And most of the time, my ranges are wider than what most of the times than what you learned, because the instructions are to every item writer on the boards is when you write a test question that where you use a lab value or a range, a value in a range, a number, go to at least 5 different books published by 5 different publishers and see what they say the range is, then make your range wide enough to fit all of those. Do you see what I'm saying? So if book 1 says 1 to 2, book 2 says 1 to 2.3, book 3 says 0.8 to 1.9, well, you got to go from 0.8 to 2.3 as your range. That way it's a fair question no matter what book the students used. So you're going to see my ranges are different, but my ranges are made to fit the NCLEX. Do you understand that? And not necessarily a particular book. So you may use my ranges and my numbers, and you may go take the like the Saunders review book with questions, or the exam cram with questions, or the NCLEX Gold with questions, and using my ranges, you may miss the question. Why? Because they went by their ranges. What ranges? The ranges in the MedSurg book that company publishes. Only one book, not 5. Now, Kaplan does what I do. Anybody that's a national reviewer does what I do, which is a wider range than normal. Okay? So here's the deal. Boards would never give you a lithium of 1.3, 1.4, 1.5, 1.6, 1.7, 1.8, 1.9. Why? It's in that gray area where books don't agree, and item writers have to get it to where all the books agree. So I teach you 2 and greater because every book agrees that is toxic. Alrighty? So don't worry about that when you see these ranges. Okay, Lanoxin. Lanoxin, what's the other name for it? I told you yesterday you have to know this. DIG. This is used to treat basically 2 things. DIG is used to treat AFib and congestive heart failure. Atrial fib and congestive heart failure. How should you have already known that it treats atrial fib? DIG. In what context did we talk about DIG yesterday? Adena, beta, calcium, DIG. Oh, so DIG is the D of the ABCDs of atrial treatment. So atrial fib, yes. And then congestive heart failure is the other big one that it treats. Well, what is the therapeutic level of DIG? 1 to 2. And you notice I'm not giving you units, correct? Because what did I tell you about units? Don't worry about it. They're not going to ask you. They're going to say, how many milligrams per deciliter of? And you just say the number. Its toxic level is greater than or equal to 2. So what do you notice about 2?
Therapeutic range.
It could be therapeutic and it could be toxic. So what do you call it when they give you a value of 2? Toxic. Why? It's safer to call something toxic when it may not be than to say it's therapeutic when it might not be. So always err on that safe side. What do you notice about lithium and linoxin's toxicities? They're the same at 2 and greater. Aminophylline. Aminophylline is a airway antispasmodic. It relieves spasms in your airway. It is technically not a bronchodilator. What do I mean by that? It is technically not a bronchodilator. What does it not do? It doesn't stimulate your beta-2 agonist cell to bronchodilate. It just relaxes a spasm. Now, when you're in a spasm, your airway is what? Narrow or wide? And when I relax a spasm, what happens to the airway? It gets what? Wider. So it actually looks like it's a bronchodilator, but it's not really a bronchodilator. Epinephrine's a bronchodilator. You know, ipratropium is a bronchodilator. Albuterol are bronchodilators. Terbutaline is a bronchodilator. This is a muscle spasm relaxer. Has anybody ever, and I'm sort of just going off the side here on these things just to see if you can apply some stuff. Have you ever seen anybody come in or heard of anyone coming in an acute asthmatic attack and the bronchodilators aren't working? That happens on occasion. Probably what's happening. Why aren't the bronchodilators working? What's that? I really can't hear you unless you talk. Okay, the inflammation, but there's a bigger reason. They're in a spasm. They're in an acute lockdown spasm. And the bronchodilator isn't going to work because the spasm's in the way. So what do you have to give them first? Some aminophylline to do what to the spasm? Relieve the spasm. Then you can come in with a bronchodilator and it will work. So just remember, when a bronchodilator doesn't work in an acute airway problem, give them a theophylline, give them an aminophylline, and that'll melt the spasm, and then the bronchodilator will work. Yes?
Do they have protocols in where they give the antispasmodic first versus?
Yeah, a lot of times when little kids come in with acute reactive airway disease, they'll slap them on an aminophylline drip and then start giving them breathing treatments with betas. And they may have 20 of them. And the first 19 may not work until that aminophylline kicks in, then the 19th one works. You see? So I've seen little kids. What's the most breathing treatments you've seen airway? Anybody ever in work ER in children's stuff ever? Or what's the most? Nobody's? Okay, well then it's a dumb question. But I have seen up to 20 breathing treatments being given in a row to these little kids. It's really just phenomenal. Okay, no, that's not typical. That's the extreme. All right, what's the therapeutic level? 10 to 20. There again, don't worry about units. 10 to 20. Any aminophylline under 10 is what? If you get an aminophylline level of 8, what's that mean? So they need to take more. Or are they taking it? Okay. If it's 21, what's it mean? It's toxic. But anything in between 10 and 20 is therapeutic. What if it's 20? Because 20 toxicity is greater than or equal to 20 on this one. So 20 could be either way, so you call it toxic if you have to. So aminophylline toxic is greater than or equal to 20. Dilantin, what is this used for? Does anybody know what dilantin or phenytoin?
Seizure.
Seizure, yeah. Its therapeutic level is 10 to 20. And its toxicity is greater than or equal to 20. So what do you call 20? Although it may be therapeutic. Bilirubin. Bilirubin is not a drug. It's a waste product from the breakdown of red blood cells. When boards test bilirubin, they will only test it in newborns. They will never test it in adults. Does anybody know what the normal adult bilirubin is? It's like 1 to 2, 1.4 to 2.3, something like that. It's really low. But in newborns have high bilirubins all the time. Why? What are they doing? Breaking down which red blood cells? The moms. So babies will run bilirubins of 5, 6, 7, 8, 9, and that's fine. Now, if I had an 8 bilirubin right now, they'd have my rear end in a bed over there finding out what's wrong with me. But a newborn with an 8 is no big deal. So what I want you to do with this bilirubin is, do you see where it says therapeutic level, the middle column? In the box for bilirubin, I want you to write the word elevated level. Elevated level. So what is the elevated range for bilirubin in a newborn? 10 to 20. So what does it mean when a bilirubin in a newborn is 9.9 and less?
Normal?
It's normal, but it's
Still high.
It's high for an adult, but it's normal. So we don't even get concerned about newborn bilirubins until it hits what number? 10. Which is 5 to 10 times more than what an adult should have. So what is the bilirubin toxicity? Greater than or equal to 20. So when do you suppose a child with what bilirubin and above do you think needs to come into the hospital?
10 or above?
Certainly before. What about before 10? No. And even at 10, 11, and 12, what are they? Is it elevated? Yeah. But you can manage it at home with sunlight, drinking a lot, flushing that bilirubin out. It's usually right about 14 to 15 that docs start thinking about hospitalizing these kids. About 14 or 15. Because once you hit 15, where are you in the scheme of things overall? You're halfway to what? You're halfway to toxic. And once you hit toxic, they can die. So you don't want it to be 18 or 17 or 19. That's way too close. You just don't like that. So, but most docs will not bring in a 12 or a 13. They'll usually wait till 14. Some docs wait till 15. I don't see any docs that wait till 16. I just typically not. Okay, so halfway through the elevated range, they start to hospitalize. Now, what do you notice about those toxic levels? What pattern do you see? 2s and 20s. 2s and 20s. Which ones are the 2s? Lithium and Lenox, and we start with what letter? So you pick the lower number with the ones with L. So lithium, Lenoxin go low. 2. Bilirubin, aminophylline, galantin go high, go 20. So you're usually picking between 2 and 20. And those are the major ones that they talk about. All right, what about kernicterus and opisthotonus? Do you see those words right there? You need to know these words, these vocabulary words. What does kernicterus mean? Does anyone know what kernicterus means? Bilirubin in the brain. When your bilirubin crosses your blood-brain barrier and it's in your cerebral spinal fluid, it's in your brain, it's in your meninges, you have kernicterus. So kernicterus, okay, what's jaundice? It's a yellow color due to
Too much bilirubin in the blood.
bilirubin in the
Blood.
skin. What's kernicterus? Bilirubin in the
Brain.
Do you see what I'm saying? So jaundice is bilirubin in the skin. Kernicterus is bilirubin in the brain. Both are due to bilirubin. It's just where is it? Kernicterus usually occurs when you get up around 20. When your bilirubin gets around 20, you start going kernicteric. Do you see why it's so dangerous? Because bilirubin, when it gets into your brain, it causes what we call aseptic. What does that mean? Aseptic. A means what? Without. Sepsis means infection. So aseptic means no germs. It causes aseptic meningitis, aseptic encephalitis, which means a sterile encephalitis due to the irritation of the bilirubin. You don't have to know all that. Just know that when your bilirubin gets to be 20, you go kernicteric and you could die. The baby could. Now, opisthotonos, does anybody know what that is? I told you we'd learn a lot of vocabulary this week. What's opisthotonos? Okay, it's a position the baby assumes when they have bilirubin on the brain. It's a position. Kernicterus is a condition. Opisthotonos is a position. And what they do is they hyperextend. These babies hyperextend due to the irritation of the meninges with the bilirubin. So these babies hyperextend. Now, what do you know about the flexibility of a newborn? No flexibility or unbelievable flexibility. Unbelievable. So when they extend, literally their heels will come up and touch their ears. They will be like in a back walkover. They'll be completely, and they'll be very rigid in that. They'll hyperextend. They almost look like they're decerebrating, if you've ever heard of decerebration. They're real hyperextending. When you see that, when you see a little kid whose bilirubin is 15, okay, kid came in, bilirubin 15, and he starts extending his neck, what do you think? Is that something that needs followed up right away, immediately, medical emergency? Yes, because he could be going into opisthotonos because he's kernicteric. And you want to catch it right away. Now, the question that often is asked on boards and other standardized tests is, in what position do you place an opisthtonic child? Now think about it. If they're hyperextending like this, what's a good position to put them in? On their side. You can't put them on their back. You can't put them on their abdomen. You have to put them on their side. Okay, that's it on drug toxicities. Just remember your 2s and your 20s. Yes?
Does bilirubin fail test based on how many hours you work every 1 day? On the boards?
Well, the only thing boards will do there is they'll talk about pathologic jaundice versus physiologic jaundice. And physiologic jaundice, the bilirubin is high and the kid is yellow at birth. With pathologic jaundice, reverse that. Pathologic, it's high at birth and the kid's yellow at birth. Physiologic jaundice, the kid's bilirubin is low at birth, normal at birth, and over the next 2 to 3 days goes high on bilirubin. So here's the deal. If they come out yellow, something's wrong. It's pathologic. If they come out yellow. If they turn yellow over the next few days, that's typical, expected. But they're just going to ask about whether it's present at birth or develops on day 2, day 3, and which one's pathologic, which one's physiologic. And they won't get any more specific than that. Which is in the blue book, so you got to remember that blue book too. Okay, dumping syndrome versus hiatal hernia. These are very commonly tested things on boards, particularly dumping syndrome. They really like to talk about dumping syndrome. It shows up a lot. Definitions. What is hiatal hernia? Well, I like to talk about these two together because they're both gastric emptying problems. And they're kind of opposites. And I like to remember opposites together. Why? Memorize one and you got the other. That's why diabetes insipidus and SIADH, I'm only going with one, figuring the other one out. Well, let's talk about what hiatal hernia is. Hiatal hernia is regurgitation of acid, meaning acid comes back up, into your esophagus, where it's not supposed to be. Because the upper part of your stomach herniates upward through the diaphragm. You're not supposed to have Your stomach is supposed to be 100% in your abdominal cavity, right? With hiatal hernia, you have a two-chambered stomach. You're like a cow. You got two stomachs. Typically, this is your thorax here. Okay, and here's your diaphragm separating your abdominal cavity below from your thoracic cavity above. Esophagus comes down like this, and then the stomach is there. It's supposed to be all below this diaphragm. In hiatal hernia, what happens is part of it goes up like this, and you've got a two-chambered stomach with a band around the middle. And what happens when you eat, it sort of sits right here and then comes right back up. That's the problem with hiatal hernia. Now, below the line there, do you see where it says gastric contents move? Gastric contents move in the right or wrong direction. Wrong direction at the correct rate. In other words, does the stomach empty faster or slower or at a normal rate? Well, it empties at a normal rate. The rate's not the problem. With hiatal hernia, the rate is not the problem. It is the direction that is the problem. It's moving in the wrong direction at the correct rate. Now let's compare that with something called dumping syndrome. Dumping syndrome, again, is a gastric problem. It usually follows gastric surgery, in which the gastric contents dump too quickly into the duodenum. Now, are your gastric contents supposed to go into your duodenum? Yes. So what's the problem? It's too fast. So in this case, the gastric contents move in the right direction at the wrong rate. So you see where they're opposites? One is correct rate, wrong direction. The other is wrong rate, correct direction. They flip-flop. So if these were speeding tickets that if these were traffic violations you got, if these were traffic violations, what would you be cited for in hiatal hernia? Going the wrong way on a one-way street, correct? What would you be cited for with dumping syndrome? Speeding. So one's a speed issue, one's a direction issue. All right, what are the signs and symptoms? Well, hiatal hernia is real easy. The signs and symptoms of hiatal hernia are just plain GERD. G-E-R-D. Gastroesophageal reflux disease. In other words, heartburn and indigestion, to state it simply. So when you see GERD, don't freak out. It's just heartburn and indigestion. No biggie. But let me tell you something. Hiatal hernia is a specific case here. You can have GERD for 100 different reasons, one of which is hiatal hernia. What makes GERD hiatal hernia is this. Hiatal hernia is GERD if you lie down after you eat. If you have indigestion and heartburn, it doesn't mean you have hiatal hernia. You could have it, but it doesn't mean you do have it. I'm going to give you 2 examples, and you tell me which one has GERD and which one has hiatal hernia. All right? A nurse gets up in the morning, skips breakfast, goes to work, passes a whole floor of meds, does a bunch of treatments, and at 11 o'clock gets epigastric burning pain, burping, indigestion, and it really, really hurts, and they gotta drink some milk or something, or it's, oh, this hurts. Do they have GERD? Yes. Do they have hiatal hernia?
No.
Why not? You aren't lying down and you didn't eat. Okay, but what about this patient? Nurse gets off at 7 p.m., goes home, eats dinner at 8 o'clock. Sits down, watches TV, half hour later eats a bowl of cereal. 20 minutes later eats a bag of chips. 20 minutes later eats, ice cream and chocolate syrup. Then they get tired, and 10 minutes later they go to bed. Half hour later they wake up with burning, epigastric pain, indigestion. They go, oh, it hurts. Same set of symptoms that the other nurse had. Could this person have hiatal hernia? Why? They laid down right after they ate. You cannot have hiatal hernia unless your symptoms occur when you're lying down after you eat. If you have GERD at a random times, you don't have hiatal hernia. Hiatal hernia is dependent upon position and meal time. That's hiatal hernia. It's just indigestion and heartburn when you lie down after you eat. Okay, dumping syndrome, and they like to test dumping syndrome, and it's a huge list of signs. The easiest way I know to remember all the things that happen in dumping syndrome is to take what I already know and combine it to equal dumping syndrome. So what do I want you to take? Well, first off, if you want to know what a person looks like with dumping syndrome, the first thing is talk about drunk. Okay, what's a drunk person look like? Staggering gait, slurred speech, impaired, judgment delayed, reaction time, emotional, what's the fancy word? Labile emotions. Well, all that can be dumping syndrome, because with dumping syndrome you do have cerebral impairment because of decreased blood flow to the brain, because all the blood's going to the gut because it dumped into the duodenum. Then you also get shock. Signs of shock, which are what? Hypotension, tachycardia, tachypnea. What's the skin? Pale, cold, clammy. Cold because you don't have any blood there. It's vasoconstricting. So pale, cold, clammy. All right, so drunk plus shock. What does that equal? What did I teach you that drunk plus shock equals? Hypoglycemia. Well, to get dumping syndrome, you add to that acute abdominal distress. And what belongs on the list of acute abdominal distress signs and symptoms? When someone has acute abdominal distress, describe them for me. Cramping, pain, doubling over, guarding, protecting. What else? What would you hear with a stethoscope? Borborygmi, thank you. Yes, hyperactive bowel sounds, but they won't say that. They'll say borborygmi. What kind of bowel elimination pattern would you have? Diarrhea. So you get cramping, abdominal pain with diarrhea, borborygmi, guarding, bloating, distension, tenderness. That all goes with dumping syndrome. So if you get a dumping syndrome question and they ask you for signs and symptoms, how do you learn them? Drunk, shock, acute abdominal distress. So here's what hopefully I want you guys to start filing things better, more efficiently. They do test alcohol intoxication, which is drunk, right? So drunk is drunk, right? You know that. Okay, shock, they'll test that too. Shock looks like shock. Do you understand this? Now, if you take drunk and shock and you put them together, what do you have the signs and symptoms of? Hypoglycemia, low blood sugar. If you throw in some acute abdominal distress with that, what do you get? Dumping syndrome. So I'm trying to link 4 of the major things they test. Shock, low blood sugar, dumping syndrome, alcohol intoxication. They all can be learned together. So what's the protocol? Drunk is drunk. Shock is shock. Drunk plus shock is hypoglycemia. That plus acute abdominal distress is dumping syndrome. And you're just, see what I'm trying to do is get you keeping adding rather than memorizing 4 separately. Okay, drunk is drunk, shock is shock, drunk plus shock is hypoglycemia, drunk plus shock plus acute abdominal distress is dumping syndrome. Okay, number 3, what's the treatment for hiatal hernia and dumping syndrome? They're going to be opposites. Because think about this. With hiatal hernia, you want the stomach to empty faster. Why do you want the stomach to empty faster with hiatal hernia? Because if it's empty, it won't what? Reflux. However, with dumping syndrome, we want the stomach to empty slower. Do you see it's the opposite? So you just remember one, remember the other's the opposite. So what are you going to do to affect stomach emptying time? Well, there are 3 things you can do. To change the way the stomach empties, you can play around with the head of the bed, you can play around with the water content of the meal, and you can play around with the carbohydrate content of the meal. All right, so let's go through this. In hiatal hernia, what do we want to do with the head of the bed during and after meals? We want it in high position. Why high? That makes gravity empty it faster. Okay, go down the column. What do we want to do with the amount of fluids we give with the meal? Would a liquidy meal or a solid meal, which one will go through the stomach faster? Liquid. So we want the stomach to go through faster with this. So we want the amount of fluids to be high or low. So high fluid. And carbs go through you really fast. Carbs go through your stomach fast. So if you have a high carb, will it empty faster or slower? Fast. So here again, you want the carbohydrate content to be high or low? High. Now, the dumping syndrome is opposite of that. So how should a dumping syndrome eat their meals? In low position, head flat. In other words, how would they eat? How should they eat? Yes. Head of the bed is what? Flat. They're turning to their side and they're eating on the side with the head down. They don't eat on the back with the head down. That would be stupid, right? But on the side with the head down. So low head of bed. What about the fluids with the meals? High or low? Low. So when would they get their fluids? Not with the meals. They'd get it, what, an hour or 2 before meals or an hour or 2 after meals, but they would never get it with the meals. And what about carbohydrate content? Low, because we want the stomach to empty slow. When everything is low, the stomach goes slow. Do you hear that? When everything is low, the stomach empties slow. In hiatal hernia, you want everything to be what? High. In hiatal hernia, everything needs to be high. So when you see hiatal hernia, you should say everything needs to be high. What needs to be high? Head, fluids, carbs. And if you want the stomach to go slow, pick everything low. Head low, fluids low, carbs low. Now be careful. What if they throw you a curve and they talk about protein in the diet? For these two. What do you think? Yeah, low protein in hiatal hernia, high protein in dumping syndrome. Because if you're low carb, you're going to be high protein. You understand that? So whatever carbs is, protein's the opposite. Any questions about dumping syndrome and hiatal hernia? They're pretty clear. This is a review, so sometimes people say, "Mark, I know most of what you're teaching me," and I say, "Good. This is called a review." So don't get upset when there's a lot of stuff you know. Get upset when it's all a newsflash. Electrolytes. How many of you in here can give me 15 signs and symptoms of hyperkalemia, hypokalemia, hypercalcemia, hypocalcemia, hypermagnesemia, hypomagnesemia, hypernatremia, and hyponatremia with 80% accuracy? How many can do that? When you raised your hand, everybody in class went, oh, not Derek. No. Anyhow, how many could do it with 50% accuracy?
Can I use my book?
No. You probably wouldn't even be able to get 50 with your book. No, okay, what about 5% accuracy? Yeah, I got takers on that. Okay, I'm going to ask you that same question in 15 minutes, and I want to see what you say in 15 minutes, all right? So let's talk about electrolytes. To know your signs and symptoms of electrolyte disorders, you need to memorize 3 sentences. The first sentence you memorize is, kalemias, do you see where we're at? Number 1 here. Kalemias. What are we talking about? Kalemia. Potassium, yeah. Kalemias do the same as. Same as goes in the blank. Same as. Same as. The prefix, except for heart rate and urine output. Potassium imbalances do the same as the prefix, except for heart rate and urine output. You memorize that. Kalemias do the same as the prefix. So what I'm telling you is when you get a kalemia, just look at the prefix. There are only 2 options, hyper and hypo. Hyper means everything is what? High, and hypo means it's low. And your symptoms will go high with hyper and low with hypo. They'll go high with hyper and low with hypo, because it's doing the what? Same as the prefix. Except for the heart rate and the urine output, which will go what? Opposite of the prefix. So with hyper, urine output and heart rate go down, and with hypo, urine output and heart rate go yes. So, in your box there, give me some signs and symptoms of hyperkalemia. Hyper. Okay, start with the brain. Give me some hyper signs in the brain. Surely you can. You know what I'm talking about, right? You're not that. I know it's the post-lunch lull, but cerebrally, if it's hyperkalemia, kalemias do the what? Same as the prefix. The prefix is hyper, so everything in the brain is going to go up because it does the same in hyper. So if you talk about the brain, what symptoms are hyper signs in the brain? Give me some hyper signs in the brain. Agitation, restlessness, irritability, aggression, obnoxiousness, decreased inhibitions, loud, boisterous, right? Those all go with hyperkalemia. All right, well, let's talk about the lungs. What are you going to see there? Tachypnea. What are you going to see in the heart? Low heart rate, because there's the exception, but the T waves will be peak, tall. The STs will be elevated. See, the only thing that goes up is the heart rate. Everything else about the heart goes with the prefix. Okay, what will you see in the bowel? Diarrhea, borborygmi. What will you see in the muscle? Spasticity, increased tone. What will you see in the reflexes? +3, +4. And all those signs, what do they have in common? They're all up. Why are they all up? Because you have hyperkalemia. And in kalemias, they do the same as whatever the prefix says they are, except for the heart rate and the urine output, which goes opposite. So what would you list for hypokalemia? Lethargy. Tachycardia, because it can go opposite there. Tachycardia and polyuria. What? Bradypnea. Bowels are going to be what? Slow down. So what might you have? Ileus, constipation, all of that. What are you going to see in your muscles? Flaccidity. What are you going to see in reflexes? +1. Do I want you to memorize these lists that we're generating? No. Because you can get those lists from the saying that says what? Kalemias do the same as the prefix except for heart rate and urine output. Are you seeing where I'm going with this? Okay. Your patient has hyperkalemia. Select all that apply. Adynamic ileus. Obtunded. +1 reflex. Clonus, which is, okay, U wave, depressed ST, let's see what I want to do here. Polyuria, bradycardia. Okay, I want you to look at it and then talk to your buddy, partner, see if you can select. But use the sentence. Kalemias do the same as the prefix except for heart rate and urine output. And draw your arrow. So you're going to have to draw an arrow. And you're also going to have to draw the exceptions, which is the heart rate and the urine output. Oh, that should say hyper. It says hype. Hyper. There's an R there. Sorry, guys. Hyper.
What about the U wave? It says just U wave.
A U wave. A U wave is a wave that goes like this.
Up and down.
It goes what? Down.
What is that?
The polyuria is up, hyper, urine goes down.
Okay, so okay, high, so everything's going
Make sure you get all your arrows right. So you need to draw a general arrow, an arrow for the heart rate, and an arrow for the urine output. Make sure you get them right.
hyper, so everything's going to go up except for heart rate and urine. So we need to go to urine, which is going to make them go low. So it wouldn't be that. So, wait a minute. Except for everything's going to go, I know it would be bradycardia because it's going to be opposite.
Bradycardia is the lowest.
It wouldn't go high, it would do opposite, it would go low. Okay, so that
Okay, how many did you select?
hyper.
Okay, I selected 2. Let me see if
got
I'm
2.
wrong. Okay? Because I'm going to write my arrows out first. I see hyper, and I know kalemias do the what? Same, so it's going to make everything go up, but heart rate's going to go down, and urine output's going to go down. Okay, A, dynamic, without movement. Ileus, that's down. That does not fit. Obtunded, that is down. That does not fit. +1 reflex, that is down. That does not fit. Clonus, that is irritability. There we go. That fits. U wave, it goes down. That doesn't fit. Depressed ST, it's going down. That doesn't fit. Polyuria, oh no, it should be oliguria. That doesn't fit. Heart rate down. Bradycardia, yeah, that fits. Now, those of you that did 3, which one did you add that you shouldn't have added?
Polyuria.
You forgot to write the... See, if you forget to write your arrows, you're dead in the water. You got to write your arrows. Then go looking. Don't look first and then go back and write arrows. You know what I'm saying? Know what you're looking for first.
Know the meaning of the words too.
Yeah, meaning of the words is helpful. Yes. The U wave. A U wave is something that starts on the baseline and goes down from the baseline. So it's a sign of cardiac depression. And the idea, though, Leonid, is if you don't know what something is on a select all that apply, don't pick it. Because everybody tends to what? Over-select by one. And isn't that what you guys did? You over-selected by one. I mean, it's like predictable. Yes?
What does obtunded mean again?
Obtunded is just a little more comatose than lethargy. So you got lethargic, and then as you go even more deep into a coma, you get obtunded. A lethargic person, ask me a question, and I'll be lethargic. Just ask me a question.
Where do you live?
No, say that.
What's your name?
Mark.
Where do you live?
Okay. See what I'm saying? Or she'd say Mark what? Do you see what I'm saying? Okay. Now that's lethargic. Okay. This is obtunded. Okay.
What's your name?
You know, what would you do? What would you do? You're a nurse. Do what you would do.
What's your name? What's your name?
You see what I'm saying? Now what's comatose? So obtunded, they pretty much you can rouse them and then they go off to la la land, and then you rouse them and they go. Lethargics will respond, but it's going to take a while to get it out. Obtundids will never respond, but they're rousable.
Okay.
Yes.
Stupor and follow obtunded?
Stupor and obtunded are often considered to be the same idea. Stupor is more a generic word. Obtunded is more the medical term. Usually, go on. I won't go there. It doesn't need to happen. Okay, calciums. Calcemias do the opposite. Calcemias do the opposite of the prefix. Which means if your calcium goes high, everything goes low. And if your calcium goes low, everything goes high. So hypercalcemia, what would you have? Bradycardia, bradypnea, flaccid muscles, hypoactive reflexes, lethargy, constipation, right? Everything goes down when calcium goes up. However, when calcium goes down, hypocalcemia, everything goes up. So what do you get with hypocalcemia? Agitation, irritability, clonus, +4 reflexes, spasm, irritability, seizure, tachycardia, all that kind of stuff. And you get two other things, Chvostek's sign and Trousseau's sign, which Hesse loves. Trousseau's and Chvostek's. Chvostek's starts with what two letters? CH. And what do you do to elicit it? You tap the cheek. So just think Chvostek's cheek. Chvostek cheek. So when you touch their cheek with Chvostek's, they go into a spasm of the face. Their face spasms. Which shouldn't happen. If I touch you on the cheek, you should go. And you shouldn't go. That would be Chvostek's. What is it a sign of? It's a sign of neuromuscular irritability associated with a low calcium. It is a sign of neuromuscular irritability associated with a low calcium. Why does that sentence make sense? Irritability, low calcium. Why does that make sense? Because calciums do the opposite. So irritability would have to be low calcium. The other sign is Trousseau's. Trousseau's is when you put a blood pressure cuff on their arm, you pump it up, and they go into a spasm of the hand. So it's a hand spasm when you put a blood pressure cuff on. So Chavostex, you do what? Cheek. Trousseau's, you do blood pressure cuff, and look for that. Stupid way I remember this. Really dumb, but it works for me. Trousseau sounds like a French name. So when I see Trousseau on a test, I think of an effeminate Frenchman. And he says, I'm Trousseau. So, so that Trousseau's. So I know it's weird, but, it may stick.
I was thinking Jacques Cousteau.
Jacques Cousteau. Okay. Board's live Hesse test. Those of you that are going to take Hesse, they will test Chavostex and Trousseau's till the cows come home on that. They'll love it. All right. Hey, by the way, what if I change this to hypercalcemia? Would it change the answer? Yeah. Because now you're looking for what? Calciums do the opposite. This says hyper, so it's going to make everything go down. So you're going to see this and this and this and not that and that and that and that and not this. Oh, you will see that. Yeah, you will see. You will see that. Yes. I'm sorry. I got a little pen heavy there. You see, so it's really. Yeah, you won't see polyuria. It's really good when you guys are better than me at this. That's what we need to be, because I'm not taking the test. You are. Okay. But do you see what I'm saying? It really is more manageable. Now, if they ask you which sets of these, like for the hyperkalemia, if they ask you which one of those was most likely, you'd have narrowed it down to two. Which two? Clonus and bradycardia. But because it was potassium, you'd give the edge to the heart. If they're talking calcium, you'd have all these things, but you'd give the edge to the muscles and the nerves. Do you see what I'm saying? So there is that little, but make sure it's the right thing first before you do it. You know what I mean? But if you're between a couple of signs for potassium that are correct, and they're asking you to pick between them, for potassium, pick the heart sign, but make sure it's going the right way for the prefix, correct? And when you're talking about the calcium, pick the skeletal muscle and nerve, but make sure it's gone the correct way. All right, let's talk about magnesium. Number 3, magnesemias do the opposite of the prefix. Now, some review books out there say that hypomagnesemia is not associated with hypertension. Because it does the what? Magnesiums do the? So a hypomag would result in high blood pressure. Some books say, no, that's not true. Check it out. Go investigate, and you'll find that low magnesium is associated with hypertension. Okay, so some of these books get a little sloppy in their answers. Who had that exam cram book yesterday?
Don't they say that magnesium often has high sodium and magnesium? So then that's kind of...
Yeah, a lot of times they'll say that when you retain sodium, magnesium sometimes gets retained. So they say that high magnesium is associated with hypertension, but no, it's really a function of the high sodium, not the magnesium.
Yeah.
If you just talk about magnesium itself, the low magnesium has the high pressure.
But then it is kind of related.
It is kind of related, but it is not a symptom of or a sign of. So, what will boards do as far as blood pressure and magnesium go? They won't even go there, because that doesn't tell them anything significant about you. It just tells you on what side of the debate are you on, that kind of thing. Just a little thing about, people have asked me about using multiple choice books to study for boards, those multiple choice books. What have I told you about them already? 1 out of 5 answers is bogus in those books. 20% of the question in those books are wrong. They are wrong. And when you do them, you think they are all, what, 100% right. And you start to doubt yourself when you're the one that knows what's right and the book is wrong. So you have to be real careful. When you do those books, do I want you to do them? Yeah. But how do I want you to do them? If you answer an answer and you know it's right, you go to their rationale, they say you're wrong, what should you say? What do I want you to say? It's bogus. I am not having my confidence destroyed. I do know what I'm talking about. The book is wrong. I mean, there was a classic one on the examgram the other day that you showed me at SASC. Which patient needs a private room? And there was a patient with Cushing's syndrome in there. Well, Cushing's people are immunosuppressed. They should be in a private room. The other patient was hyperthyroid. And they said a hyperthyroid should be in the room because they don't sleep well because they're hyperthyroid. And if they had a roommate, they wouldn't be able to sleep real well. Well, my opinion is between somebody that isn't sleeping and somebody that's immunosuppressed, there's no... Any nurse you ask would say, do you see what I'm saying? So you got to watch those books. And then even in that book, which is the book I like the best, I think it has the best questions of any book. I have real problems with it. In one of the chapters it said that hypokalemia is not seen with Cushing's. Absolutely it is. With Cushing's you've got a lot of what? Aldosterone, which makes you retain sodium and water. Well, to retain sodium in the loop of Henle, what do you have to kick out? Potassium. So you do get hypokalemic. And then in chapter 8 or 9, they ask about it again, and they say that you do see hypokalemia with Cushing's. So in chapter 3, they say you don't, and in chapter 8, they say you do. That's the state of the art of those books. Do you see what I'm saying? So when you go do these books, and you know your stuff, and you're ready to go, and it's telling you, no, you're wrong, you're wrong, you're wrong, you're probably what? You're right, you're right. You're right.
Better proofreaders.
Well, they just, they're not, they're putting out a product to make money.
Right.
And the faster they can get it done, with the fewer people looking at it, the more money they make. Okay? We took, 3 faculty at Cedarville took the HESI test, and there's 160 questions. We disagreed with 30. And your faculty would too, if they took the test. They would disagree. And with ATI, they would disagree with even more. But they've never taken the test, so they don't even know what's on it. Do you see what I'm saying? They don't even know what's on it, and they're asking you to take it, and they're making decisions based on something they've never seen. And I'm telling you, they will. You tell them. You said, you take that test. You take that test, and you see if you disagree with, and they'll disagree with. I guarantee they'll disagree with at least 10 to 15%, if not 20 to 30%. They really, really will. But that's no excuse to get a 650 on the HESI. You understand what I'm saying? If you disagreed, if you missed all the questions that were bogus on HESI, you know what you'd end up with? If you missed all the ones that were bogus and you got like 80% to 90% of the ones that really were valid, do you know what score you'd end up with a HESI? An 1100 something. You see, so that's not going to flunk you on. You know what I'm saying? I'm telling you 2 things. I'm telling you they have a lot of bad questions on there, but those bad questions aren't going to be what? Don't say, oh, they're going to get. No. You have to not know some things too. All righty? Question?
Oh, I was just going to say, a lot of people, they weight so much on the ATI that if you get below a level, you get 15 points off your whole points system, so that could totally...
I would just, when after you graduate, that's the best time to go back and just ask them and say, have you guys taken the ATI? No, have you taken it? No, honestly, have you taken it? Do you know what's on it? Have you seen those questions? Do you know what the question? Have you done a quality inspection of the product that you're putting? Do you know the product that you're putting so much weight on? See, I wrote my test. I wrote my final in my course. So I know. So when I say you fail it, I say you fail it because I wrote that test and I know that test. But a test I don't know, how do I know what it's like? These products are not that fantastic. The boards is fantastic. These products are not. You You see what I'm saying? No, but then having said that, I'm saying that there's no reason not to get a reasonable score on these, even with those horrible questions. Okay? All right. But I just want, what I don't want you to do is this. I don't want you to learn a lot, know a lot, go take these questions and take 100 of them and have your confidence totally destroyed because they don't agree with what you said. Do you see what I'm saying? And you tend to only focus on the ones that you didn't agree with, not the 100 you did get right. You tend to focus on the 4 or 5 that you missed. Isn't that the way we are? Mm-hmm. So don't let those destroy. How many find that doing those batteries of questions are the fastest and quickest way to destroy your confidence? Yeah, and that's not what they should. That you shouldn't even be doing them if that's what it's doing. Do you understand what I'm saying? Okay. All right. So magnesiums do the what? Opposite. Now, can you have a tie? Could it be possible that a certain symptom could be caused by a magnesium imbalance or a calcium imbalance or a potassium imbalance? Could that happen?
Yeah.
Sure. So how do you break those ties? Well, here's the tiebreaker. In a tie, don't pick magnesium. Why? It's not a major player. So it's probably not the magnesium that's causing the problem. Number 2, if it is skeletal muscle or nerve, blame it on calcium. For everything else, blame it on potassium. So let me show you what I'm talking about here. I'm talking about this kind of question. Your patient has diarrhea. What caused it? Hyperkalemia, hypokalemia, hypocalcemia, hypomagnesemia. All right, now, you know it's an electrolyte question, right? So you know you're going to be playing games with arrows, correct? So, is this symptom up or down? So you got to find something that causes stuff to go up, the bowel to go up, right? Okay, potassiums do the what? Same. So hyper makes everything go. So could that cause that? So that's a possibility, is it not? Kalemias do the same. Hypo makes everything go down. Could that cause that? No, that's out. Calciums do the opposite. So hypo makes everything go up. So could that cause that? Yes. Remember, they're in the same direction that could cause it. Magnesiums do the opposite. So hypo makes everything go up. So could that cause that? Yes. So we have a what? Tie. So what don't we pick in a tie? So we rule out D. Is this skeletal muscle or nerve? No. So what do we rule out? Calcium. So we blame it on the high potassium. Are you seeing how that works? Let me show you another one. What if it said tetany? Is that up or down? Up. So let's do the same. Kalemias do the same. So hyper makes everything go up. So could that cause that? Yes. Same, down. No, that would be out. Calciums do the opposite. So low calcium makes everything go up. So could that cause that? Yes. Magnesium does the opposite. So low makes everything go high. So could that cause that? Yes. So we have the same three-way tie we had with diarrhea, correct? Now, what do we rule out first? The magnesium again. Is this skeletal muscle? Yes. This is skeletal muscle and nerve. So now we blame it on the what? The calcium, and we don't go any further. Now let me show you what mistake people make with electrolytes. Your patient has tetany. What caused it? A high potassium. B, a high calcium. C, a low magnesium. Do you know what 90% of students taking this question without understanding what I just taught you would pick for this one? The high calcium. Because they've got burned in their brain calcium muscles, calcium muscles. If it's muscle, it's calcium, right? So they're going to pick high calcium and they're going to be dead wrong. Why? It's going the wrong way. You've got to use your sentences first. Potassiums do the same, so this could cause that. Calciums do the opposite, so that's going to make everything go down. That would be ruled out. See how the answer that everybody would pick should be the first one ruled out, because they're not using what? Their sentences. And they just think muscle, calcium, potassium, heart. And they don't even look to see if it's going the correct direction. How many think you might have done that? If it's potassium, it's heart. If it's calcium, it's muscle. And then you don't even look at the prefix. Okay, so look at the prefix first, then use potassium, heart, calcium, muscle for tie breaking. Yes?
So if it was low calcium, or I'm sorry, low calcium, you pick that then over potassium.
This could cause that. This could cause that.
That's specific.
And this could cause that. Okay, now our tiebreaker is in a tie. Don't pick magnesium. If the symptom involves skeletal muscle, which it does, pick the calcium. And you don't have to go any further. But you got to go through for the first time to make sure that your prefix agrees with the symptom. You have to make sure that that imbalance would actually cause it. Then you go break your tie. Second, what most people do by mistake is they use the tiebreaker first. Do you see what I'm saying? They rule out magnesium. For skeletal muscle, they pick calciums. And for everything else, they pick potassium. And they don't even look to see if it's even feasible. That's the problem that people have. Question? Okay. All right, let's turn the page and talk about sodiums. Do you see the one with the E? I want you to write dehydration using it like an acrostic, like a crossword puzzle. Put the D over top the E and then write hydration down. The one with the E, hypernatremia, is associated with dehydration. You see over in the other column, the one with the O? Write the word overload down from that. Overload. Aren't dehydration and overload opposites? So when you get a hypernatremia, what should you see? The letter what? E, which tells you it is the same as dehydration. And when you see hyponatremia, you should see the O and say that's the same as fluid overload. So here's how you would use this. The one with the E is dehydration. The one with the O is overload. And you're using sodium here. So if they said this, a student nurse runs to you, the LPN, and says, oh my goodness, I just ran an IV, a whole liter of IV fluid into the patient in 10 minutes. I forgot to close the clamp. Okay? Ran a whole liter in 10 minutes. I forgot to close the clamp. What electrolyte imbalance would you expect to see? Why did you say hyponatremia? Because they would have had fluid overload and you'd have been absolutely 100% correct. Which patient is put on a fluid restriction and Lasix? Hyponatremic. Which one is given lots of fluids? Hypernatremia, because that's dehydration. Who has hot, flushed, dry skin? That describes what? Hypernatremia, so that's the one with the E, so that's dehydration. So here's my point. If you had a 20-question test over dehydration and fluid overload versus a 20-question test on hypernatremia and hyponatremia, which one would you rather take? dehydration overload. But what's the reality? It's the exact same test. Because anytime you see dehydration, you say what? Hypernatremia. Whenever you see overload, you say hyponatremia, and vice versa. So in addition to a high potassium, what other electrolyte imbalance is possible in DKA? In DKA, what other electrolyte imbalance is possible? Hypernatremia. Why? Because wherever you see the word dehydration, you can throw in the word hypernatremia. Anywhere you see hypernatremia, you throw in the word dehydration. So what nursing diagnosis would be major for hyponatremia? Hyponatremia. What major nursing diagnosis? Fluid volume excess. Exactly. Or SIADH would have hyponatremia. DI would have hypernatremia. And HHNK would have hyper, because HHNK is the same as dehydration, which is the same as hypernatremia. Is that sort of easier for you? Okay. So what do you have to know your electrolytes? Here's what you have to know. Kalemias do the same as the prefix except for heart rate and urine output. Calciums and magnesiums do the opposite. The one with the E is dehydration. The one with the O is overload. That's it. Now, if you use those, kalemias do the same as the prefix except for heart rate and urine output. Calcium and magnesium do opposite. The one with the E is dehydration. The one with the O is O. Could you give me 15 signs and symptoms of hyperkalemia, hypokalemia, hypercalcemia, hypocalcemia, hypermagnesemia, hypomagnesemia, hypernatremia, and hyponatremia with 80% accuracy? Who could do it? And are you memorizing stuff? No, because those lists won't stay. Okay? So, but you need to memorize what? Kalemias do the same as the, except for calcium and magnesium do the one with the E is, the one with the O is. Okay, so learn that. Otherwise, learn your lists. Have at it. Be my guest. Okay, the earliest sign of any electrolyte disorder is numbness and tingling. The earliest sign. So if they said to you, what would be the first thing you would see? What would you say? Numbness and tingling. Now, vocabulary, this word means numbness and tingling. Paresthesia. So boards will say paresthesia instead of numbness and tingling. One thing they love to say is circumoral paresthesia. What's that mean? Numb and tingling lips. So that's a very, very early sign of these electrolyte disorders. The universal sign of electrolyte imbalance is muscle weakness. All electrolyte imbalances cause muscle weakness. They all do. Does anybody know the fancy word for muscle weakness? Paresis. You need to know those two words, paresthesia and paresis. Paresthesia is numbness and tingling. Paresis is muscle weakness. All right, that's it on signs and symptoms. Let's talk about treatment. And the only treatment they're really going to test is potassium. All righty? First rule, never push potassium IV. Everybody knows that? Yeah. Good. Never push potassium IV. Number 2, not more than 40 of K per liter of IV fluid. Now, LPNs, you probably don't have to worry about this, but RNs, on your test, if the doctor writes an order for 60 of K in the liter, you're supposed to call and clarify. 40 of K, you don't call, you don't clarify, you just follow the order. But if it's over 40, you question and clarify. That's pretty standard. Okay, 3 and 4. Numbers 3 and 4. These are ways to lower a potassium. Why is a high potassium such a bad thing? It stops your heart. Cardiac arrest. So what is the most dangerous electrolyte imbalance of them all? High potassium. Of all the electrolyte disorders, the worst one is a high potassium. It beats all of them because it can stop a heart. So we need to know how to lower that potassium. So number 3 is the fastest way to lower the potassium, and that is give D5W with regular insulin. Give D5W with regular insulin. What's that going to do? It's going to drive the potassium into the cell, out of the blood. And it's the potassium in the blood that will kill you, not the potassium in the cells. So does D5W and regular insulin get rid of the excess potassium? Yes or no? No. What does it do with it? It hides it. Hides it where? In the cell. Does it really solve the problem? No. Then why do we do it? To save their life. Sometimes it's so high and that heart is being so negatively affected that we got to get that potassium down fast. We don't have time to solve the underlying problem. We don't have time to get the kidney kicking it out. We just have to get it out of the blood as fast as we can do it. It's sort of like your floor is dirty as all get out. Company's coming in the driveway. So what do you do to the dirt? Sweep it under the rug and throw the rug back down because you don't have time to what? Really clean the floor. That's the way this is. With this, we're just sort of sweeping the potassium under the rug. Now, what's going to happen over the next few hours after this works? It lowers the K. Fantastic. Now, what's going to happen over the next 8 hours? The potassium is going to leak right back into where? The blood, where it could kill you again. So this is, what's the upside of this one? Fast and quick. What's the downside? Temporary. Which is why we use the other one, K-exalate. Now K-exalate goes into your gut. It either is put through your mouth or through your rectum, in enema or a ingestion. And it's full of sodium. It's chock full of sodium. Now, as it sits in your gut, what do you think it liberates into the blood? Sodium. But to maintain electronegative equilibrium, what has to be kicked out of the blood into the gut? Potassium. And where does it's picked up by the K-exalate. So the K-exalate goes in full of sodium, but it trades sodiums for potassium. So when you defecate the K-exalate out, what's it full of? Potassium. Now how did your blood start out? High in what? Potassium. It ends up high in sodium. So you have what imbalance? Hypernatremia. That's the one with the E. So that is just simply dehydration. So we give them fluids and we correct that problem. So what we're doing is we're trading a non-life-threatening electrolyte imbalance for a life-threatening one. You know what I mean? We're getting rid of a life-threatening imbalance and giving them a non-life-threatening imbalance. But they still have an imbalance when we're done. Now, what's the good side about K-exalate? What's the good side? What's that?
Does it last longer?
It lasts longer, yes, but there's a reason why. It lasts longer. Why? It gets rid of the excess potassium out of your body, never to reoccur. Okay, well, what's the downside of K-exalate? Well, yeah, you get hypernatremic, but that's not the worst downside.
Takes
it takes a long time. It takes hours, and you may not live that long. So what's the advantage of D5W regular insulin? What's the downside? Temporary. What's the upside for K-exalate? Permanent. What's the downside? Takes a while. So what do you think we do simultaneously? We give them both. What lowers the potassium right away? D5 regular insulin. As it starts to come back out of the cell, who picks it up? K-exalate, and out it goes. So, let me ask you this. What electrolyte does K-exalate work with? For calcium, magnesium, or potassium? Potassium. What's the symbol for potassium? Now, does K-exalate make potassium enter the cell or exit the body? Does it do it fast or slow? Early or late? Say that real fast. Okay, so the minute you see K-exalate, what should you think? K exits late. Potassium leaves the body, but it's going to take a while. Well then, so if K exits late in K-exalate, then what happens with D5W and regular insulin? K what? Enters early. Do you see what I'm saying? So if you know that K exits late in K-exalate, then you know what D5W and regular insulin does, which is the opposite of that. It doesn't exit, it enters, and it doesn't do it late, it does it early or fast. Okay? Do the practice question at the bottom of the page using the rules that I taught you. Do not use your normal thinking. Use the rules that I taught you. I want you to think through it. Remember, if a answer is part wrong, it's all wrong. And when you get an electrolyte question, what is it all about? Drawing what? Arrows. Yeah.
I don't know what it is, but it's such a cute question to call. But you know that there's something too you can also give. It's only temporary though. It protects the heart. I feel like it's calcium.
Yeah, you can give it. Yeah, calcium gluconate can work. Yeah. No, that's more of an emergency situation. They're going to ask about treatment that you're going to do on a unit in a non-code, non-emergency, yeah. Okay, what answer did you guys come up with? D. How many said A? B, C, D. Okay, how hard was this question? Scale of 0 to 10. 0 being easy, 10 being unbelievably difficult. What would you give it? 1. 1, 2, 3. An hour ago, what would you have given it? So what did you see? What did you notice? What word did you notice? Hypercalcemia. Calciums do the? So it's going to make everything go. A negative inno, negative chrono, negative dromotropic effect right on the heart and everything else. Okay, so what's wrong with A? Why did A not get your answer? Tacky, killed it. Why did B not get your answer? Elevated. Why did C not get your answer? Tall. So what was good about D? Decreased, inverse, inverted, blocked. Right? Okay, good job. And you don't have to, see the nice thing about it is you don't have to, it's actually testing your knowledge of the principles of what it does. But you don't have to memorize all fancy stuff, okay? All right, take a break. Come back at 20 at half past. $60 mil per drop. No, 60 drops per mil. And micro is the same. They're synonymous. No. Which leg of yours is weak one? You hold it on the side. And advance it with the wheel. Yes, the one that goes by itself. This is the weak one. That goes together. And then I go like this, and now I'm on my bad one by itself, which is cool. And the weak one gets the bad one. Can you see how wide the base of support is? Yeah. That's better than having it over here when you're on zero. Okay. Let me ask you. Your client had a right CBA. In which angle is it? CBA, so you're left CBA. Really? Right, no. Y'all have to pay attention next week.
You are doing the clip in term three. All around time.
Okay, let's start. Endocrine overview. Endocrine glands. This lecture is going to be real helpful for HESI stuff because they love to test adrenals and thyroids. The endocrine overview is only going to be about thyroids and adrenals. You do not have to know the thymus, the pineal, the parathyroids. You don't have to know all those. Just know your thyroid gland, know your adrenal gland, and you're good to go. Now, if you don't know your thyroid, you're in trouble. If you don't know your adrenal, you're in trouble. So focus on what you need to know. So let's focus on those two glands. The first one is hyperthyroidism that I will talk about. Whenever Mark Klimek sees the word thyroidism, he turns it into metabolism because that's what the thyroid does. The thyroid regulates metabolism. So when you see hyperthyroidism, what do I want you to turn it into? Hypermetabolism. If that is true, do you see that now you do not have to memorize the signs and symptoms? They're just logical. What would be the logical set of signs and symptoms you would see if you had a high metabolic rate? Weight loss. So they're skinny and weight loss. What else? What would their pulse rate be? Blood pressure. Their personality. Irritable, hyper, obnoxious, excitable. Life of the party for about 5 minutes till everybody gets sick of them. Heat. What? Intolerance and cold tolerance. So they can tolerate the cold because they're like a little furnace. They cannot tolerate the heat because they're already burning up. Exophthalmos. What's exophthalmos? Bulging eyes.
What was the word for that?
X-E-X. E-X-O-H-P. O-P-H-T-H-A-L-M-O-S.
Oh, okay, I got it now.
Exophthalmos. So they're skinny, they're hyper, they're tacky, they're hypermetabolic. The person I remember this dates me too, you guys probably do not know him, was a guy named Don Knotts that was, what was he? He was Barney Fife on Mayberry. You know, the skinny little guy, Sheriff Andy. He's always hyper, bug eyes, skinny, classic hyperthyroid guy. The name of this disease is Graves, Graves, Graves disease. Now, they will not tell you, they will not say Graves disease, hyperthyroid. They'll give you one name. And you're supposed to know Graves is hyperthyroid. The way I remember that is a saying my grandma used to say, which is, you're going to run yourself into the grave. What two words does that link? Run with grave. Well, if you're run all the time, what are you? Hyperthyroid. So running yourself into the grave helps me remember it's hyperthyroid. Number 3, the problem here is hyperthyroidism. So you have 3 treatment options. You have 3 ways to treat hyperthyroidism. Number 1, radioactive iodine. Radioactive iodine. Now there's 2 things you need to know about radioactive iodine. Number 1, the patient should be by themselves for 24 hours. They should be in a room by themselves for 24 hours. And after that, they have to be real careful with their urine. They should flush 3 times. If they spill their urine on the ground, they need to call the hazmat team, because somebody has to come with a Geiger counter to make sure it's all cleaned up. So if you have a patient on radioactive iodine for hyperthyroidism and they spill urine on the floor in the hospital, you can't call housekeeping. You got to call your hospital hazmat team, and they come with all their paraphernalia. It looks really, really silly for them to go worrying about the urine. But that's where the radioactivity is excreted, is through the urine. So this is the one place where they have glow-in-the-dark urine. Not really, but you have to treat it like it's bad. So the only risk to you, the nurse, for a patient who's had radioactive iodine is what? Their urine. And give them a private room in the first 24 hours. Okay, the next treatment we have is PTU. PTU. A drug. Yes?
Would you get family visitation on that? Is that an issue? I've seen several ATI questions.
With radioactive iodine, no family visitation in the first 24 hours. And if they go home, they are supposed to stay in the family room and nobody else, or they stay in their bedroom, nobody else goes in for 24 hours. So there's a restriction of visitors, home restriction for 24. After 24, they can have all the visitors in the world as long as they don't pee on them. Okay, the second problem is PTU, propylthiouracil. Propylthiouracil. Now, I don't want you to memorize that PTU is propylthiouracil. What's it used for? Hyperthyroid. So what must it do to your thyroid? If it treats hyper, what must it do? Bring it down. So I want you to remember that PTU stands for puts thyroid under. Whenever you see PTU, what should pop in your head? Puts thyroid under, which tells you it treats hyperthyroid. Its primary use is for cancer. It's a cancer drug. But one of its special uses is for hyperthyroids, because it will also put the thyroid under. So what do you think the number one nursing thing is with this drug, if it's a cancer drug? Immunosuppression. So what blood values do you have to watch when they're on PTU? Their white blood cell counts. So it puts the thyroid under, and it also knocks down your white count. The most common way, however, that we treat hyperthyroid is surgical removal. We do a thyroidectomy. Thyroidectomy. We remove part of the thyroid or all of the thyroid. Now, if you want to get your thyroidectomy questions correct, you must pay attention to whether they're talking about a total thyroidectomy or a subtotal thyroidectomy. Because that's going to make a huge difference in your answer. If you just treat all thyroidectomies the same, you will miss loads of questions. So what's the most important thing in a thyroidectomy question? Total or sub. Now, I taught this one time, and a student called me the day after and said, what you taught didn't help on thyroidectomies. And I thought, okay. And I said, well, what didn't help? And she said, well, there was a different kind of thyroid surgery on there that you didn't cover. I thought, boy, that's interesting. Total, subtotal. That pretty much covers it for me. You know, I can't think of, it's either total or it's subtotal. I mean, what third possibility could there be? And I said, well, what was it? And she said, it was a partial thyroidectomy. Subtotal is a partial, total is a complete. So a complete thyroidectomy is a total, a partial is a subtotal. Now, she passed. So you don't have to be, a real shining light. You just have to do some shining. She certainly was not a shining light. Why did she make such a dumb mistake? She wasn't managing her anxiety. And she was looking for total and subtotal, and it wasn't there. She panicked, and she didn't say, now wait a minute, which of these is closest to what I do know, right? Because it may not say it exactly the way you want it. Remember the guy with the cracker and the dry carbohydrate? They'll say things differently than you learned them, but it means the same thing. If you see something on the test that means the same as something you learned, but it's saying it differently, guess what? It is what you learned. Don't say, well, that sounds like the same thing, but I didn't learn it that way, so it's probably not that. Oh, that is the worst thing to do. You should do the opposite. You should say, that sounds an awful lot like what I learned, which was this. It's not the same phrasing, but it sounds like that, so it must be that. Do you see the difference? Always assume that if they tell you something synonymous, that it means the same as what you know. Don't assume it's something different. Always assume it's what you know. Okay. So for totals need lifelong hormone replacement. Why? Because if I take your whole thyroid out, you don't have any. So you got to have lifelong hormone replacement. Also, letter B, you are at risk for hypocalcemia. Why low calcium? Why, after a total thyroidectomy, do you have a low calcium? Because it's almost impossible to spare the parathyroids when you take the whole thyroid out. So you end up with low parathormone, low calcium. So they're at risk for low calcium. What are the signs and symptoms of hypocalcemia? We talked about that last hour. Calciums do the opposite. So hypocalcemia is going to make everything go up. So you're going to have tetany, spasm, irritability, clonus, seizure, tachycardia, hypertension, irritability, jitteriness, tremor. Right? What's the first sign that's going to happen? Paresthesia. Excellent. See, once you start learning enough, things start cycling around and it's all no news, right? It's old news. What two signs will you have? Chavostex and Trousseau's. Because your calcium is low. Okay, subtotal thyroidectomies, on the other hand, do not need lifelong replacement. Why? Because you got some left and it's supposed to kick in. Might you be on hormone replacement for a little while? Till that other one kicks in, then it's supposed to be off. Do you think you get the hypocalcemia much with this? No, because if you only take out part of it, you can spare your parathyroids and your calcium's fine. However, what these people are at risk for is something that totals never get, and that is thyroid storm or thyroid crisis. Same thing. It also has another name, thyrotoxicosis, which sounds like a toxic thyroid, so that sounds like hyperthyroidism to me. Thyroid storm. Now, what are the symptoms of thyroid storm? 4 really bad things. Number 1, super high temperatures of 105 and above. Number 2, extremely high blood pressures. Stroke category. So you're probably talking 210 over 180. Now I'm just giving you that as a ballpark. That's no set in stone number. Severe tachycardia, probably in the 180s. Could be as high as 200. And there again, that's just a ballpark. There's nothing magical about that number. And lastly, they are psychotically delirious. They have psychotic delirium, which we talked about before. These people are in a medical emergency. This thyroid storm is a very, very bad thing because it can cause brain damage, and brain damage is permanent. You literally fry your brain to death with hypoxia and or hypoxia. So you must treat this immediately, and what you treat it with is get the temperature down and get the oxygen up. Get the temperature down, get the oxygen up. Well, how do you get the temperature down? What's the first way you would do it? Ice packs. What's the best way? Cooling blanket. Because if you would pack him in ice without the cooling blanket, use the cooling blanket without the ice, which way would be better? Ice without the cooling blanket without the ice. What's better? Cooling blanket without the ice, so the best is the cooling blanket. But what would you do first? First I'd put him in ice, then I'd order the cooling blanket and have it there. So you see there's another first best difference. And what would you give how do you get the oxygen up? Oxygen per mask at 10 liters. Just as an interest note, what's the problem with that order? What do you think you experience when you try to implement that order? What's that? And these people are what? Psychotically delirious. So how likely is it you're going to keep an oxygen mask on this patient? Yeah, good luck. Good luck. So this is a medical emergency. You pack him in ice, order the blanket, throw a mask on him with high O2. And they will come out of it themselves without treatment, or they will die. And there's nothing you can do to make it go either way. It's just when that T3, T4 gets out of their system, they'll be okay. We don't want to medicate them, because if we medicate them, it could go the other way. So this is a self-limiting condition. All we're doing is sparing their brain until they come out of it. Now, I've seen this about 5 times in my career. The longest lasted 12 hours. The shortest lasted about less than 2 hours. But when you're treating these people, it's 2-on-1, meaning 2 staff for 1 patient. You need an aide and yourself, because you can't do it with just yourself. Yes?
What is Tylenol going to do?
Tylenol works in the hypothalamus, and at this point the hypothalamus is being severely threatened because it's right near the pituitary, and the problem with the thyroid storm that caused it was the TSH from the pituitary. So that pituitary hypothalamic axis is part of the problem that's causing this situation. And Tylenol works in that hypothalamus, and it's not going to work. Tylenol just isn't going to do it. So you really have to, you know, pack them in ice. So you really don't treat a lot of it. It's kind of scary because you're just sitting there, you know, doing what you can. All right. But I would say that good nursing care is going to save their life. Why? Because medicine isn't. Yes, question?
So you said, to clarify, first ice packs and then oxygen later.
Well, I mean, if you had to pick between the ice packs and the oxygen, I would do the oxygen first, the ice pack second, the cooling blanket third. But if I was between the ice packs and the cooling blanket, the ice packs go first. But I would always pick stay with my patient. Because you don't leave your patient to go get the oxygen. You see what I'm saying? But it's a perfect world, so it's sitting right there. All right. Post-op risks. They love to ask you about thyroidectomies and post-op risks because it depends on the type of surgery and it depends upon the time frame. So let's talk about this. You've got to know this. You have to know this. In the first 12 hours, it doesn't matter whether it's a total or a subtotal. It does not matter. The top priority is airway. Because where's your thyroid? So if you have edema in the area, what's it going to press on? The airway, the larynx, so trachea, so you've got to watch out. Second big problem is hemorrhage, because it's an endocrine gland which has a lot of blood vessels. So the top two in the first 12 hours for both types of thyroid surgery are airway and hemorrhage, which is pretty much standard, isn't it? Okay, now where the difference comes in is in the 12 to 48 hour window. If they give you a patient who's longer than 12 hours, but less than 48, now you have to pay attention to what type of thyroidectomy was done. Letter A, the post-op risks 12 to 48 hours after a total. The big danger is tetany due to the low calcium. For a total, they get the tetany because of the low calcium. However, letter B, the post-op risks 12 to 48 hours for a subtotal is storm. What storm? Thyroid storm. So you see where they're different? But they're the same in the first 12 hours, but different in the next 36. So, 12 to 48 hours after surgeries, what do totals get? What do subs get? Totals get tetany, subs get storm. Totals get tetany, and subs get storm. So TTSS. Total tetany, sub, storm. Total tetany, sub, storm. TTSS. When? 12 to 48 hours after surgery. In the first 12, what is it? Airway and hemorrhage, airway and bleeding for everybody. All right. What's the big risk after 48 hours, by the way? Infection. Right? How long does it have to be before you're allowed to pick infection as a high priority? At least 42 hours. We'd prefer 72. Here's the deal. Never pick infection in the first 72 hours after anything. So if they had a trauma and it's been 36 hours, would you pick infection? No. They gave birth to a baby 8 hours ago. Would you pick infection? No. Never pick infection in the first 72 hours. You only pick infection after 72 hours, not in the first 72. Question?
Is tetany serious?
Tetany is dangerous because your larynx can go into a tetanic laryngeal spasm, which would close the vocal cords in an irreversible spasm, which essentially cuts off your airway, and you die. Okay, hypothyroid. Hypothyroid is hypometabolism. So if hypothyroid's hypometabolism, what are the signs and symptoms of a low metabolic rate? If your metabolic rate is really low, what would you look like? Obese. What would your personality be? What's that? What? Flat, boring, dull. Cold intolerance, heat tolerance. See, you cannot tolerate what you are. So if you're cold, you can't tolerate. You have cold intolerance. If you're hot, you have heat intolerance. Do you see what I'm saying? So hypos are always what? Cold. So they have cold intolerance. Hyperthyroids are always hot. So they have heat intolerance. So you cannot tolerate what you are. What would the pulse be and the blood pressure be? Low. If they were a test taker, what kind of test taker would they be? Slow, extremely slow test takers. They tend to get lower grades in school. Not because they're not smart, but because they can't process fast enough. It could even affect nursing practice in the sense that you don't think fast enough. Okay, the name of the disease is mixed edema. M-Y-X, M-Y-X, and then the word edema. That's the name of it. Okay, the treatment. Do you have too much hormone or not enough hormone? Not enough, so what's the logical treatment? Give them thyroid hormones. Synthroid, levothyroxine. Number 4, caution. Do not sedate these people. Why do you not sedate them? Because they're already super slow. You sedate them, you'll actually put them in a coma. It's called a myxedemic coma. So what pre-op order would you question with this hypothyroid patient? Ambien at HS, the sleeping pill before surgery, the night before surgery, because they don't need that. Now, let me ask you this. You got a hypothyroid client. He's on thyroid pills every day. He's going to have a open heart surgery. He's scheduled for it in the morning. Doctor orders NPO past midnight. You got a problem with that? What's your problem? Call and question what?
That they're holding the med, the thyroid hormone.
Okay, because NPO means nothing, and nothing means nothing, including anything, which would be a pill. So nothing by mouth means they're not allowed to have any of their oral pills, which means you would not give the person their morning thyroid, which means they would be hypothyroid and very susceptible to any drug that would sedate them. Do you get any drugs during surgery that sedate you? It's called an anesthetic agent. Do you see what I'm saying? So if you would follow that order and not give the thyroid pill the morning of surgery, what could likely happen to your patient? Never make it off the table. They would die from these depressant effects of the anesthesia. So you as a nurse would never hold what pill before surgery without express orders to do so. Thyroid pills. Never hold your thyroid pills unless they tell you to do it. And even if they told me to do it, if I called the surgeon and he told me to hold the thyroid, what would I do? I'd call the anesthesiologist. And if he said hold it, what would I do? I'd call the head of the anesthesiologist, my supervisor, and say, hey, look, this is not cool. Now, my supervisor should what? Contact the supervisor of the anesthesiology and say, hey, look, what's going on here? You see, you aren't supposed to go up the ladder outside your department. You go up your department and they go across. Do you see what I'm saying? If I really felt it was unsafe, I would refuse to follow. I would just refuse to. I don't know. You understand? If I thought it meant a patient dying, how far would you go? You know what I'm saying? If it was your dad, what would you do to keep him from going to surgery? You'd lay down on the floor and not let him get the cart over your body. Do you know what I mean? So I'm just saying, would you do the same for your patient? Okay, enough said on that. Adrenal cortex. The second gland we're going to talk about, the adrenal cortex. Interestingly, adrenal cortex diseases start with either the letter A or the letter C, which are the initials of adrenal cortex. So could Graves be the adrenal cortex?
No.
Could myxedema be the adrenal cortex?
No.
Could pheochromocytoma be the adrenal cortex?
No.
Could Cushing's?
Yes.
Conn's? Addison's?
Yes.
Corticoinsufficiency?
Yes.
Adrenal insufficiency?
Yes.
Yes. So all of those diseases start with an A or a C. Now I didn't say that all diseases start with an A or a C, or adrenal cortex, because asthma, obviously, no. All right. Addison's disease. Let's start with Addison's. It starts with an A. It's under secretion of the adrenal cortex. Under secretion. What are the signs and symptoms? Just two things you need to know. They are hyperpigmented. What does hyperpigmented mean? Very tanned. Very tanned. So they look what many people call healthy, but they are the farthest thing from it. Because the second thing you need to know about it is these people do not adapt to stress. They do not adapt to stress. Because their adrenal gland is under secreting. So if they undergo any stress at all, what could happen? What's the purpose of the stress response, I might ask? What's the purpose of the stress response? Not to increase the metabolism necessarily, although it will. That's what mediates it, but that's not the purpose of it.
Heart rate.
That's what it does, but that's not what the purpose. What? Okay, but what's the big when you are under stress, there's a threat to your brain. And the purpose of the stress response is to perfuse the brain with blood, in other words, support the blood pressure, and give the brain glucose, which means raise the blood glucose. So the purpose of the stress response is to raise the glucose, raise the blood pressure. Does everybody understand that? Your stress response is supposed to raise your glucose and raise your blood pressure. That's what its purpose is. If these people do not have the adrenal cortex to carry out the stress response, when they undergo stress, what will happen? Okay, what's the purpose of the stress response? Raise the And if you've got a disease in that organ and cannot do that, what will happen when you undergo stress? Your glucose will go down and your blood pressure will go down and you'll go into shock like that. And it doesn't take much to put them into shock. In fact, these people have been known to go to the dentist, have a tooth filled, and they go into full-blown shock because of that stress, which wouldn't bother most of us. If you ever work squad, these are the people that you happen on the scene of a little fender bender, and somebody's gone. No blood pressure, nothing. They're gone. And you think, well, they couldn't possibly have been hurt that bad. Well, what you'll search them, and what will you find?
Really nice thing.
A really nice, a really tan guy wearing a bracelet. And what does the bracelet say? I have Addison's disease. These people, you look at them wrong and they go into shock. No, not really, but I mean, they are your time bombs waiting to go. This is a very scary disease. You're okay until something happens, and then wham, they decompensate like that. Yes?
I thought it was rare. Do you see it?
It's very rare. As far as endocrine disorders, it's one of the rarest. It's one of the rarest. It's like for every 600 Cushing's patients I would see, I see one Addison's. And that's probably being generous. I probably have only taken care of 2 or 3 Addison's patients in my entire life. Cushing's, all the time. Kennedy was supposed to have had this disease. JFK was rumored to have this disease. So that means when he got shot, what? There was no chance. There was no. I mean, even if it had been now, and if it hadn't gotten hit in the skull, if he had gotten like a shoulder injury now, he might not have made it. So it was. And think about this. What's really dangerous to people with Addison's disease? Stress. You're the president of the United States. It's not the best. He probably couldn't get elected right now because they would have made such a big deal of the you know what I mean? It would have disqualified him. But it was hidden. People didn't know about it. What's that?
He didn't seem very tan.
Well, he was a little bronzer though. Early years he wasn't. He was real pasty. But then he got tanned as he went on. And then he started taking steroids, so he got puffy.
Okay, yes.
So the nice little puffy cheeks he had there near the end, that was steroids. That wasn't Jackie. Okay. Well, what's the treatment?
Steroids?
Yeah. Give him what he's low on, which is what? Steroids. Not pump you up steroids, but glucocorticoids. All drugs that end in what? What do all steroids end in? Sone. Beta-methasone, beclomethasone, dexamethasone, prednisone, mometasone, hydrocortisone, fludrocortisone. So drugs that end in sones are steroids. So you give these drugs to people in Addison's, right? So Addison's disease, is it under secretion or over secretion?
Under.
Do you have to take something away from them or add something to them?
Add.
And what do you add? A sone. In Addison's, you add a sone. And that tells you doesn't Addisone tell you whether it's hyper or hypo? Sure, because if you're adding, it's what? Hypo, and it tells you what drugs to pick, anything ending in sone. So just remember, Addison's, you add a sone. And that'll help you remember it. Cushing's syndrome. This is over-secretion of the adrenal cortex. Over-secretion. The way I remember this is, if you have a cushy bank account, do you have more or less money? More. If you have a cushy chair, does it have more or less stuffing? More. If you have a cushy tushy, do you have more or less? More, yeah, you got a whole lot more, right? A lot more. So, cushy just sounds like more to me, doesn't it? Cushing's, cushy, over. Addison's, you got to add because it's under. I never forget which one's under and which one's over. Okay, now, the signs and symptoms of Cushing's disease, you have to know this. They will test this, and knowing this list gets you what we call 2 for the money, which means when you memorize this list, you're actually getting 2 things. Number 1, you're getting the signs and symptoms of Cushing's, and number 2, you're getting all the side effects of steroid medications. So when you memorize this one list, you're getting two things: Cushing's signs and symptoms and side effects of steroids. Any drug ending in some. So that's good for a lot of reasons. Now, I am going to have you remember this by drawing a picture of a little man. And I'm serious, I want you to draw this little guy over and over and over again until you draw him perfectly. Because if you can draw him perfectly, guess what? You know the signs and symptoms of, and you know the side effects of any drug ending in some. So here's what it goes. Now this man is called Cushman. Okay, Cushman. Now, I'm going to draw a head, but don't draw the head real big because you need a really space for a really big body. Okay, so don't take up all your space with the head. Okay, the first thing on the head is you need to draw a moon face. Okay, he's got a moon face. And you say, oh, I can't draw. Okay, well, can you do this? That'll do. Okay. So draw a moon face. Whatever your skill set is, just draw a moon face. Because that's the first symptom, moon face. Puffy moon face. Then, draw a beard on him. What's the fancy term for excess hairiness on the body? Close. Hirsutism. Hirsutism. That means lots of hair. Hirsutism. Okay, next, draw a real big body, and I mean a big one. Put a bump on the front. Oh. And a bump on the back. Put a bump on the front and a bump on the back. Now, what's the bump? Okay, let me ask you this first. What do we call the big round body? Obesity, but a certain type of obesity. Truncal or central obesity, they'll call it. Because see, your arms and legs aren't fat. It's just your body. Your arms and legs are actually really skinny. So it's truncal or central obesity. That's the big body. What's the bump on the front? No. The buffalo hump is the bump on the back. Because buffaloes have a bump on their back. So that's the buffalo hump right there. This is the gynecomastia. Gynecomastia. Those are female tight breasts on men. They sort of wear the bro. If you remember Seinfeld. So you have gynecomastia and buffalo hump, as well as the central obesity. Now, I want you to draw a skinny arms and skinny legs. Skinny arms, skinny legs. Because they have atrophy of those muscles. Those muscles waste away. All right, then I want you to fill him full of what? What's that? Water. So he's retaining what? Sodium and water. He's retaining sodium and water. So what's he losing? Out the back. What's he losing? Potassium. He's losing potassium. Okay, put some striae on him. What are striae? S-T-R-I-A-E. Stretch marks. He has these stretch marks on his abdomen, striae. Then, the most important one of all to remember, this is the most important one, put high glucose if you have room. High glucose. Because this causes them to be hyperglycemic. They look like diabetics. So if you're on a steroid and you're diabetic, talk to me. Diabetic, put on a steroid.
A lot of insulin.
What's that?
You need a lot of insulin.
You need more insulin because the steroid is going to increase the blood glucose and you're going to go out of control. What's that?
And you're immunosuppressed.
Yeah. Now I want you to put bruises all over him. Because what does he do real easily? He bruises extremely easily. We're almost done. We only have 2 things left. The last thing is I want you to make him say something. You know how they have those little cartoon speech balloons? Have him say something, and what he says is, I'm mad. I have an infection. I'm mad. I have an infection. Well, that tells you 2 things about him. What's the first thing it tells you? He's grouchy. He's irritable. And secondly, he's immunosuppressed. So if you ask me, Mark, what are the signs and symptoms of Cushing's syndrome, or what are the side effects of steroid meds, I would close my eyes. Why? I'd be picturing him and I'd say, okay, moon face, hirsutism, central obesity, gynecomastia, buffalo hump, retaining water and sodium, losing potassium, high glucose, wasting extremities, striae, bruising, irritability, and immunosuppression. And who did I describe? Cushman. I have this vision, and I went down through and chung 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 chung. Because you're going to see it. One of the famous ways that people ask it is they'll give a person with an acute exacerbation of COPD, in which they need Solumedrol, a steroid IV push every 8 hours to reduce the inflammation in the airways, and it's a steroid. And they'll ask what nursing action needs to be taken when they're on this steroid. Accu-Checks Q6. Because what do steroids make your sugar do? Go up, even if you're not diabetic. And if you are diabetic, look out. Okay, so you got Cushman? I'm serious about drawing him because if you don't draw him and don't learn him, many of you in here are going to say, oh, nuts, when you get onto your test, because you're going to wish you had. You're going to wish you had. Okay, now what's the treatment? Well, the question is, do you have too much or too little here? Too much. What's the classic treatment for hypersecretion of a gland? What's the number 1 treatment for a hypersecretory gland? Cut it out. So adrenalectomy. But what happens if you do a bilateral adrenalectomy, do you think? If you do a bilateral adrenalectomy. What does that mean? Do you have any adrenals left? So what do you have? Addison's. Okay, now think about it. Why did you do a bilateral adrenalectomy? What did you look like that made the doctor do a bilateral adrenalectomy? Looked like Cushman, right? So he did that to prevent that. But once you do that, you can induce what disease? Addison's, for which you give a steroid ending in "sone," the side effects of which now make you look like Cushman, which is why you had the surgery. So it's really frustrating. I mean, it takes like a year or 2 to get them equilibrated back to where they're feeling normal. And that's the problem with endocrine surgery, is the endocrine surgery creates the opposite problem, which for which you have to take the hormone, the side effects of which make you look like the thing you had in the first place. So think about if you're hyperthyroid, high thyroid now. What's the major treatment? Thyroidectomy. And if you do a total thyroidectomy, what do you induce? Hypothyroid, for which you have to take thyroid pills. What are the side effects of thyroid pills? They look like Graves' disease, which is the reason you had the surgery in the first place. You see, any endocrine gland works that way. It's really frustrating to these poor people, and it takes years to get it back to normal. Okay, let's finish up. For today, we have probably 2 things to do, and we'll be done. Let's talk about toys on page 33. Kids' toys. Children's toys. This is a lecture about selecting the appropriate play activity or toy given the age of the child, generally speaking. Now, when you select toys or play activities for children, there are usually 3 things to consider. I'm just going to walk over here, I'll keep talking. 3 things to consider. The first one, is it safe? The second one, is it age appropriate? Third one, is it feasible? You have to make sure that the toys you're using are safe, age appropriate, and feasible. Sorry, my back's killing me. I can't stand anymore. First thing, safety. Safety considerations when you're thinking of toys. There are 3 things you have to consider with safety of a toy. The first thing is, number 1, no small toys for children under 4. If you've got a 4-year-old kid or younger, you should not pick a toy that has small parts they could aspirate. If they're over 4, guess what? The small parts are just fine. So 4 is your cutoff age for small pieces, parts to toys. Second thing you consider for safety. Number 2, no metal, M-E-T-A-L, no metal toys if oxygen is in use. If they're getting oxygen. Why? Sparks. Does anybody know a fancy word they might use in place of metal? That means the same thing as metal? Die-cast. D-I-E-C-A-S-T. Die-cast. If they say a die-cast car, they're talking about one of those little metal matchbox thingies. And that's a no-no if oxygen is in use. Third safety consideration, number 3 safety consideration, and this is more vocabulary than anything. Write down, beware of fomites. F-O-M-I-T-E-S. Beware of fomites. Now you guys should be asking me, what in the world is a fomite? A fomite is a non-living object that harbors microorganisms. It has to be non-living, and it harbors microorganisms. By the way, just to see if you know your epidemiology, what do you call a living organism that harbors microorganisms?
Vector.
A vector or a host. But this is a non-living, so it is a fomite. Now, why in the world are we talking about fomites with kids? Toys are notorious fomites in a pediatric ward. They stick them in their mouth. The next kid sticks it in their mouth. I mean, it's just really bad. So toys are horrible. Now, which toys make worse fomites than other toys? What toys are the worst fomites? Stuffed animals. What makes the best toy because it's unlikely to be a fomite? Hard plastic. What can you do with hard plastic toys that you cannot do with stuffed animals? You know, bleach them till they're dead. You know what I mean? You can terminally disinfect a hard plastic action figure. Okay? You can't terminally disinfect Tickle Me Elmo. All right? So if you have a child that is immunosuppressed, what would be the best toy for that child?
Hard plastic.
A hard plastic action figure. All right, those are the safety considerations. Feasibility just means could you do it? And it's pretty common sense. For example, can a 13-year-old, is swimming a good activity for a 13-year-old? Is it safe for a 13-year-old? Is it age appropriate for a 13-year-old? Is it feasible for a 13-year-old in a body cast? No. See, so feasibility can come into this too, but that's just going to be common sense. In other words, feasibility means could you actually play it with this child in the situation they're in? Okay, the next one is age appropriateness. This will take up the majority of the lecture because this is what they test mostly. Is they want to know if they give you a kid of a certain age, what toy should you give them? So let's start out with the first year of life, infancy. From 0 to 6 months of age, the best toy is a musical mobile. The best toy is a musical mobile. Because these kids are sensory motors. They are sensory motors. So the best toy is something that stimulates both motor and sensory. That's why the musical mobile is best. However, if the boards does not have musical mobile there, your second best answer is to look for something hard, meaning what? You know, something that can be distant. No, did I say hard?
Yeah.
It needs to be soft right now. But it has to be large. Why large?
They don't choke on
So they don't choke. Why soft? So they don't hurt themselves. What's the problem? Well, what the problem is, what do you do with a 3-month-old who is supposed to have soft toys if that 3-month-old is also immunosuppressed? You see the treatment problem there? Boards won't go there because that's a conflict of two principles. They're just happy you know the principles, period. So don't go there. But you do see the inherent problem in that, don't you? Okay. Now let's talk about the 6 to 9 monthers. The 6 to 9 month olds. These kids are working on a skill called object permanence. Have you heard of object permanence? What does that mean? Yeah, the idea that it's still there even if you cannot see it. For example, if a child does not have object permanence, if I put their favorite toy under a blanket, what will they do? Cry. Because it's what? Gone. Into that, third dimension, that 8th dimension, never to be seen again. If a child has object permanence, and you put their favorite toy under a blanket, what will they do? Rip off the blanket and grab the toy. You see, it's very different. Now, at 6 to 9 months of age, your play should be teaching them that. That is the big task they need to learn intellectually. So you should play with them with toys and activities that teach them object permanence. So the best toy is what I call a cover-uncover toy. Cover-uncover toy. Now, I cannot tell you exactly what toy they will use. Okay? But I can tell you what kind of toy you should select. So you should select for a 6 to 9er, you should select a toy where you cover it up and then you uncover it. then you cover it up, and then you uncover it. What is that teaching them? Object permanence. So could you give me some examples of cover, uncover toys? Jack in the Box. Those pop-up pals. Remember? You push the right button, then they pop up, then you push them down, then you pop up, and then you push them down. Those books that have the little windows, and then, where are the birdies? Oh, there they are. Where are the birdies? Oh, there they are. Where's the birdies? There they are. And you're covering and uncovering the little picture of the birdies in the nest. That's perfect for this age group. Fantastic. Playing peekaboo. Why? You're there, then you're not. Then you're there, then you're not. That's good. Putting a blanket over your head and then uncovering your head and then putting a blanket over your head. That's really cool. That's good. And then what you do is they start laughing, and then you stop doing it and see if they're learning. Because if they're learning, they'll pull the blanket off and laugh. If they don't, they'll go. Actually, do you guys know much about dogs? That's how you test a dog's intelligence. Because one of the highest order cognitive skills a dog can perform is object permanence. And if you throw a blanket over your dog and it just sits there like this, you got a dumb dog. If you throw the blanket over the dog and he goes, then you got a good dog. You got a smart dog. So you'll know how dumb your dog is tonight. Some of you are saying, I do that to my husband and he doesn't take nothing. All right. Well, what's the second best toy if a cover-uncover toy does not show up? Something large, but it should be hard, firm. So you can make it of plastic, wood, metal. So how old does a child need to be before they're allowed to play with anything made of wood, metal, and hard plastic? At least 6 months of age. By the way, what is the worst toy in the world for a 6 to 9 month old kid? The absolute worst toy. The musical mobile. What was the best toy for a kid before 6 months? The musical mobile. What's the worst toy for a kid after 6 months? The musical mobile. Why? Because now they pull themselves up, they sit up, and they strangulate. Many, many kids have had strangulations or near strangulations from the musical mobiles that should have been taken out of the nursery months ago. Okay. The next age group are the 9 to 12 monthers, right? And these kids are working on vocalization. They're learning to speak. So what kind of toys are best for these kids? Speaking toys, talking toys, verbal toys. Now, I'm not going to give you a specific one because I don't know what they're going to test. But this is going to be like Woody the Cowboy, Teddy Ruxpin, Tickle Me Elmo, Slap Me Susie. I don't know them, all of them. They're just sort of, all those ones where you got a what? You got a string, and you pull the string, and it says something. That's really cool. See and Say, Barnyard Friends, the cow says moo. Fantastic for this age group. Talking toys. What kind of books? Talking books. Really good for this age group. If we just talked about books alone, what's a good book for a kid under 6 months? Soft booking and go what? Right? What's a good book for a kid 6 to 9er? Picked window books. What's the best book for a 9 to 12er? Speaking books, talking books. All right? The other thing about a 6 to 9er that's down here is purposeful activity with objects. Purposeful activity. In other words, how old does a child have to be before they'll do anything purposeful with a toy? At least 9 months. So let me ask you this. Could a 7-month-old play with 3 wooden blocks? Could they play with 3 wooden blocks? Is wood okay? Because they're over 6 months, they could play with 3 wooden blocks. Could a 7-month-old build a tower of 3 wooden blocks? Why? Why no? Build is a purpose word. And you cannot pick any answers that have purpose words in them until the child is at least how old? 9 months. So here's the deal. Never pick answers with the following words in it if the kid is under 9 months. Never pick an answer with the following words in it if the kid is under 9 months. So here are those words. Build, sort, stack, make, construct. Why? Those are purpose words, and a kid does nothing purposeful before age 9 months. I tell people, a baby's in the womb how long? 9 months, and it's another 9 months after they're out till they do anything purposeful. Prior to that, it's all random. Okay, let's talk about the toddlers, which are the 1 to 3 year olds. They are, the best toy for them is a push-pull toy. Something that you push, something that you pull. Now, I don't know what it's going to be, but give me some examples of push-pull toys. The lawnmower, the wagon, the buggy, that stupid popcorn poppery thing. What else?
Strollers.
Yeah, baby strollers. The little dog with the floppy feet that you drag behind you. So anything that they push, anything that they pull, fantastic for 1 to 3 year olds. Work on the gross motor skills. Work on gross motor, which is running, jumping. I always say, if it takes finger dexterity, no for the toddler. If you're sitting there thinking, now which of these activities could a toddler do? If any of those activities take finger dexterity, do not choose it for the toddler. Toddlers do not have finger dexterity. So, could they use colored pencils? No. Scissors? No. Not even blunt scissors they can't use. So anything that requires finger dexterity is no for the toddler. The interesting thing is, people have misnamed finger painting. Finger painting is not finger painting. Finger painting is hand painting. Can toddlers do finger painting? Yes, because it takes your hand, not your... Do you ever see a toddler go... with their fingers? No, they go... So it's hand painting, not finger painting, okay? So can they do anything that takes finger dexterity? No. But they can do finger painting, because finger painting isn't finger painting, it's hand painting. That's where people get confused. Does that make sense? Okay. They're characterized by parallel play. Parallel, which means you play alongside but not with. You play alongside but not with. Okay, let's talk about preschoolers, the next age group, the preschoolers. Work on their fine motor. So what do you pull out now? Things that take
Pencil.
what? Finger dexterity. So you need to, preschool is the finger dexterity. Number 2, work on their balance. So tricycles, tumbling class, dance class, ice skates, those are okay at this age. Don't put your toddler in dance class, gymnastics class, and hockey class. Not going to work. When they turn preschool, they'll learn in 2 weeks everything they would have learned in 2 years as a toddler. So it's a waste of your money. Yes?
What about swimming lessons?
Swimming is different because that's more gross motor. In some sense, it doesn't really depend on balance. So infants should actually be taken for swim lessons because of safety issues. So an infant should be taught how to swim, at least know how to be used to being in the water, at least, so that it's not a, I would say probably, I don't know what age. Anybody know the age where swimming is?
They start at 3 months.
0 to 3? I was going to say as soon as you want.
You can get them in.
That's what I
The
thought.
water, it's a parent-teacher class until they're in preschool. And
Yeah.
then once they hit preschool, then they're on
Their own.
group class.
But I don't think there's any lower limit. I think, like you said, 0 is what I know. Okay. What else? Okay, they are characterized. Work on balance. They're characterized by cooperative play. Cooperative play, which means what?
Play together.
As opposed to parallel. Parallel plays alongside but not with. Cooperative plays with. So they play with each other in groups. They interact and play together. And lastly, they like to pretend. They are highly imaginative. That their pretend play is big. You be the sheriff, I'll be the saloon keeper, you be the barmaid, I'll be the outlaw, and you all role play. I grew up in Youngstown, Ohio. I always got to be the Pope. Role play. I was the one with the wagon, so I got to be the Pope. Okay, I know you care. Okay, the next age group is the school age. And the school age kids are characterized by the 3 C's. They are creative. In other words, let them make it. Don't you make it and give it to them. In other words, would it be good to give them a coloring book and crayons? What would be better? Blank paper and colored pencils. Because then they can create their own pictures rather than fill in the blanks, Would you give them plastic cookies, plastic lemonade, and plastic donuts and have them have a tea party? No. Could they have a tea party? Yes, but what would you do with a school age? They make the what? Cookies. They make the lemonade. They make the muffins, and they have you see what I'm saying? That's why Legos is such a good toy for this age group. Why? They're building and making. They're creating. You don't give them trucks and cars, and you give them things that they make into cars and trucks and that kind of thing. That's why Transformers is good, because it makes the creativity and all. Okay. Second C, they are collective. They're always collecting something. Beanie Babies, Pogs, Digimon, Pokemon, Webkins. What was the stupid one this Christmas? Zuzu Pets. Yeah, Zuzu Pets. All that kind of stuff. And don't the toy manufacturers know this? Oh yeah. Remember about 5 years ago, of course I had girls. So 6 years ago, Mattel came out with Barbie and the not 2, not 4, not 6, not 8, not 10, but 12 dancing princesses. Because they knew that all the little girls would want what? All 12. So why would you give Barbie and the 2 dancing princesses? I mean, that's stupid. What a bad marketing plan. Go 12. They'll buy them. So that's toys. They know all this stuff. And last C, they are competitive, which means they like to play games where there's a winner and a loser. Now, they don't like being the loser. I never said that. But I'm saying that if you go over here to the 5th grade, to the nearest elementary school, and you tell them, we're going to play a game, what do they say? Yeah, cool, get out of school, play a game, cool. But if I tell those 5th graders, guess what? Everybody's gonna win. Nobody's gonna lose. We're all gonna get the same prize. What will they say? Stupid game. Just give me the dumb prize and don't waste my time. But if I tell them, hey, we're gonna play a game, $400 and a bike for the kid that wins. Oh my goodness, I'll have those kids doing all of them, tipping cows, you know. They'll be doing everything. So they like competition. Now what about preschool? Make a statement about competition in preschool. No, not unless you want a room full of screaming, crying kids. Who wins in preschool? And what do they get? The same prize. And I'm talking the same prize. Don't go in with orange lollipops and grape lollipops. Go in with one size, one flavor, and if they don't like it, they don't get it. Don't go in with two. You're going to have a Chernobyl. Forget about it. Adolescents, what's their play? Peer group association. Peer group association. They want to what?
Hang out with their friends.
Hang out with their friends. So do they do much?
Sleep.
Have you ever seen a group of teenagers? I have girls, so I'm suspicious as a father. So I built a rec room on our house so that the pool table and the TV and everything would be at whose house? Ours, so that all the people would come to our house so I could keep a little. I didn't tell about the closed circuit television in the, no, I didn't. But they would all come over to our house, 20 of them. And guess what they'd do? 20 of them. So I'd go in the room and I'd say, how about if we play pool? Dad, get over here. Well, how about if we watch a movie? Dad. So for 4 hours. And I go in and here's my daughter. Texting. And I say, Emily, who are you texting? Bethany. Bethany who? Bethany Wales. Emily, Bethany's sitting right over there. Yeah, I know. They're texting each other in the same room with all these boring teachers doing nothing. I know, I'm old, forget it. But they just hang out. Now, what's that got to do with nursing? Here's the deal. If they gave you a question where a gang of teenagers, 5, 6, 7, 8 of them, were hanging out in one teenager's room, what do? Do you let them or not let them?
Let them.
You let them. Unless one of 3 conditions is happening. Here are the 3 things that would, well, no, not what you're thinking. Unless one of these 3 things is true, you let them hang out. The first thing is, if anyone is fresh post-op. In other words, if any one of those teenagers, adolescents, is less than 12 hours out of surgery, they shouldn't be hanging out. Okay? Second thing, if anyone is immunosuppressed, they shouldn't be, for obvious reasons, correct? And thirdly, if anyone has a contagious disease. So if you've got 13 kids hanging out in one room, unless somebody is fresh post-op, somebody is contagious, or somebody is immunosuppressed, let them hang out. Get over your control issues. Let them hang out. All right? Let's do the last lecture of the day, laminectomy. Laminectomy. What page? 38. I'm not going to do lab values at this time of day. Your brain will go totally fried. Laminectomy. Lamina are the vertebral spinous processes, and ectomy means removal. So laminectomy. Ectomy means removal, and the lamina are the vertebral spinous processes. Vertebral spinous processes. Now, what are the vertebral spinous processes? Well, let me ask you this. Have you ever felt the bumpy bones on the back of somebody? You're not really feeling the body of the vertebrae. You're feeling those wingy thingies out the back. Those are the lamina. So in a laminectomy, do I remove the round bodies of the vertebrae? No, you'd be an invertebrate if I did. That wouldn't be good. What I'm removing is those wing things out the back. I remove those. So we're just removing the posterior processes of the vertebral bones. Just part of it. Now the question is, why in the world would you do that? What's the reason for a laminectomy? The reason is to relieve nerve root compression. To relieve nerve root compression. Because sometimes when the nerve roots come out of the spinal cord, there's like calcium or herniated discs or inflammatory masses pressing on them, and that causes problems. So we cut away that bone to give the nerve more room to exit. So it relieves the compression on the nerve root. Well then, what are the signs and symptoms of nerve root compression? The 3 P's. Pain, paresthesia, which means what? Numbness and tingling. And paresis, which is muscle weakness. Pain, paresthesia, and paresis. Those are the 3 signs that your nerve roots are being pressed upon, for which we would do a laminectomy to remove those back bony parts so that your nerve roots can come out real nicely and not be pressed on. Now, when you get a laminectomy question, the most important thing to pay attention to is the most important thing that you pay attention to in any neuro question. Does anyone know what the most important thing to pay attention to in any neuro question is? Location. It is location. If you want to get a neuro question correct, pay attention to the location of the problem, because the location will determine the symptoms. The location will determine the prognosis. The location will determine the treatment. Location is everything in neuro. There are 3 locations for laminectomies. They are cervical, thoracic, and lumbar. Cervical, thoracic, and lumbar. Cervical means the neck, thoracic means the upper back, and lumbar means the lower back. Now, in the rest of this page, I'm going to illustrate for you how, when you change the location, you change the answer to the question. So let's talk about it. Is the next one F or E? E. Letter E. What is the most important pre-op assessment for a cervical laminectomy? What's the most important word in that question?
Cervical.
Cervical. Okay, so the cervical spinal cord innervates 2 things: diaphragm and arms. Diaphragm and arms. That's what your cervical innervates. So, if you are doing a pre-op assessment for a patient going for a cervical laminectomy, what is the most important thing you would check out before surgery? What? Breathing. Why? Cervical innervates the diaphragm. So breathing is number 1. Check out their breathing. How are they breathing? Number 2, if that is not there, if breathing isn't there, the next best answer is the function of their arms and hands. That would be your backup answer. So what's number 1 answer for cervical? Breathing. What's number 2 answer for cervical? Arm and hand function. However, letter F, what did I change in the question?
Correct.
Location. I changed it from cervical to thoracic. And when I changed location, I changed the Answer. It is no longer breathing and arms and hands. For a thoracic, the most important assessment is the cough and the bowels. Cough mechanism and bowels. Cough and bowels. So what would be the most important thing to assess before a thoracic surgery? How well the patient coughs. Not so much gag, but how they cough. So what I want you to do is this. I want to illustrate how this is. Your thoracic spinal cord innervates your abdominal muscles and your gut muscles. So what I want to do is I want you to do this. I want you to put your hand on your abdomen, on your abdominal muscles. I want you to cover your mouth, and I want you, on my signal, I want you to cough. And when you cough, I want you to feel what happens here underneath your hand. Okay, ready? Cough. How many felt a contraction? Great. Okay, now, I'm going to give all of you a thoracic spinal cord injury. Okay? Okay, you got it. So now you can no longer contract what? Your abdominal muscles. So relax them. Relax them. You're paralyzed. There. You cannot contract those muscles. You're paralyzed. Okay, now, put your hand on your abdomen. They're paralyzed. Cover your mouth. And this time on my signal, I want you to cough. But don't you dare contract these muscles because you're not allowed to because you're paralyzed there. Okay, ready? Cough. Wow, some of you actually got a good cough out. Usually that's impossible. Somebody has to cheat. No, but do you understand? So in order to cough, what do you have to be able to do? Contract these muscles. And if you can't contract these muscles, you cannot cough. You can go, but you can't cough. Can you breathe? You can breathe, but you cannot cough. So what assessments do you have to make for a thoracic? Coughing and bowel sounds, right? All right, but what about G? What did I change in G? The location. And when I change the location, I change the answer. The lumbar innervates the bladder and the legs. Bladder and legs. So what's the most important assessment before lumbar laminectomy? Yeah, when was the last time they voided? Is their bladder distended? Or is it empty? You need to know that before surgery. And then, if that's not there, what's the backup answer? Function of arms and legs. So that's important, knowing that. So cervical is what? Cervical is breathing and arms. Thoracic is coughing and bowel. Lumbar is bladder and legs. Okay, let's turn the page and talk about post-op laminectomy. The number one post-op answer on NCLEX for laminectomy is log roll. If you have a question that says log roll your patient and it has anything to do with spinal cord, including laminectomy, what's your top answer?
Log roll.
Log roll. You always pick log roll if it's there. You cannot go wrong by picking log roll. Now, in addition to knowing that, there are three other things you need to know about mobilizing clients after spinal surgery. Number one, do not dangle these people. Do not dangle them. Now, dangle does not mean to hold them by their ankles out the window. What does dangle mean? Sit on the edge of the bed, which is what we do for everybody. Isn't that the first thing we do for all post-ops? Dangle them. What am I telling you about these people? Don't do that. Go from lying down immediately to what? Walking around. None of this dangle business. Now, can they sit on the edge of the bed long enough to overcome orthostatic hypotension? Sure, but they shouldn't sit there for 10, 15 minutes dangling. Yes?
So will it be specified as like feet flat on ground, sitting on edge of bed?
Sitting on edge of bed with feet flat on ground is not appropriate for a fresh post-op laminectomy. If they say sitting at the side of the bed long enough to overcome orthostatic hypotension, then it's okay for a laminectomy. But if they say sitting with the feet on the ground, sitting with the feet not on the ground, dangling, none of that for a lamb. Sitting is a horrible position for a lamb. Okay, number 2 restriction. Do not sit for longer than 30 minutes. They're not allowed to sit for longer than 30 minutes. So what kind of typical post-op order would you question with a laminectomy? What typical post-op order would you question with a laminectomy? Up in chair for 1 hour, TID. Isn't that real common? Up in chair for 2 hours, TID. Real common. Up in chair for meals is really not bad. Because how long does a meal usually last? About a half hour. So that's not bad. Because they would say up in chair for meals is good because you're only up for a half hour. So they'd say that's okay. Third thing, they may walk, stand, and lie down without restrictions. They may walk, stand, and lie down without restriction. So there's only a restriction on what position? Sitting. All the OSHA studies since 1970s have proven what is the one hospital worker position designation that has the highest incidence of back injuries. What worker in the hospital has the highest risk of back injuries? Not nurses. Not nurse aides. Admitting clerks. Because what do they do all day? Sit. And that's worse than lifting and slugging 200-pounders in the bed. It's worse for you. It's terrible. So sitting is horrid position for your back. Okay, let's talk about post-op complications. What will the post-op complications depend on? Location. So what would be the number 1 post-op complication after a cervical laminectomy? Breathing. But breathing is not a complication. It's a good thing.
Shortness of breath.
They won't breathe very well and very deeply after surgery. They will have trouble breathing deeply after surgery. What will develop? Pneumonia. Yes, pneumonia is the number 1 complication. Why? Because they don't breathe so well. Why? Because it's a cervical. And cervicals don't breathe so well after the surgery. Because that's the location that hits the lungs. Okay, well what if they change it to a thoracic? The post-op complication after thoracic, what would it be? Well, what won't they do so well? Cough. So what will they get then? Pneumonia. And they'll have an ileus because their bowels won't work. But what's the number 1 problem after a lumbar laminectomy? Urinary retention, followed by problems with the legs. Do you see where they could trick you? And they could say, a person underwent a lumbar laminectomy 10 hours ago. What's the number 1 problem? A, airway. B, breathing. C, circulation. D, urinary retention. What would be the answer? Urinary retention. Because they don't have A and B and C problems because it doesn't affect them. You see? So that's not what they would do. Let me ask you this. You are caring for a patient with a lumbar oligodendrogliosarcoma. What is the number 1 problem? A, airway. B, ileus. C, cardiac arrhythmia. D, urinary retention. What would be the answer? D. Because it's a what? Lumbar. And it doesn't matter what it is. You don't have to even know what this is. This does not determine your answer. What determines your answer? Location does. So all you have to do is, if you know that cervical is breathing and arms, thoracic is cough and bowels, and lumbar is bladder and legs, you got the whole thing. Because all you have to do is look at the location, because the pathology doesn't matter. Could I put a lumbar abscess? And wouldn't it be the same thing? Lumbar surgery, same thing. Lumbar spinal cord injury, same thing. Lumbar ependymoma, same thing. So what determines pathology in neuro? Location, which makes it actually easier. Okay? Okay, next thing. Typically we don't have chest tubes with laminectomies, but the anterior thoracic will have chest tubes. Letter C. Letter C, the anterior thoracic will have chest tubes. What does anterior thoracic mean? Anterior. From the front, through the chest, you go to the spine. Well, if you get to the spine through the front of the thorax, you're going to have a pneumohemothorax and need chest tubes, right? Okay. Number 5, laminectomy with fusion. And the key word here is with fusion. That means they take a bone graft from the iliac crest. So laminectomy with fusion involves taking a bone graft from the iliac crest. Here's what they do with this one. Here's your vertebrae. Here's your vertebrae. Here's your disc. If they take the disc out, you cannot have bone on bone. So they have to take some bone from your hip, bring it over here, put it in between these, and fuse it so that you don't have that grinding. So this is a laminectomy with fusion. Not all laminectomies have fusion. Most laminectomies don't. In most laminectomies, all you're taking off is this wing thing out the back, and you're not messing with the disc. But if you remove the disc, then you got to do a fusion. And you got to get bone from somewhere, and one place we get it is from the patient's own hip. So if you have a laminectomy with fusion, how many incisions will the patient have? 2. One where? Hip, and one on the spine. So turn the page. Of those 2 incisions, which one will have the most pain? The hip will. Believe me, that hurts. Which one has the most bleeding and drainage? The hip. That's where the hemovac will be. That's where the JP will be. Which one has the highest risk for infection? Actually, they're equal. They have a 50-50 chance of infection. And which one has the highest risk for rejection? The spine. So if you look at the 2 incisions post-operatively, which one causes the most problems? Which one causes the most problems? The hip does. So surgeons are wanting to get rid of that hip incision. Why do the surgeons want to get rid of that hip incision? Because it's shorter recovery, a lot better, no problems, cuts the infection rate in half, decreases the drainage by 80%, decreases the pain by 80%. A lot better all the way around. Hospitals love it because they get money for shorter stay. They make more profit. That's why here it says surgeons are using cadaver bone from bone banks. Why? Yeah, because if they're going to cut this disc out, they can take bone from a dead person, put it in between your bones and fuse it, and there's not that second incision. So they use that quite a bit. There is a slight increased risk of rejection, but not that bad because bone is not protein, and protein is what triggers the antigen-antibody response, the immune response. Nowadays, they're even moving away from cadaver bone to guess what? Synthetic. bonding substances that we are developing in the lab. But that's not on boards yet. Okay, discharge teaching. Is this important? Oh yeah. Discharge teaching, very, very important. There are 4 temporary restrictions and 3 permanent ones after laminectomies. The first temporary, do not sit for longer than 30 minutes. How long do you think that restriction applies? How many weeks? 6 weeks. If you have to guess how long something should be restricted and you do not know, you should always pick 6 weeks, because that will pay off for you. If you know how long to restrict it, then pick that. But if you don't, pick 6 weeks. You'll be surprised at how well that pays off. Number 2, lie flat and log roll for 6 weeks. Now that doesn't mean you have to actually do it for 6 weeks continuously. That just means when you do turn, log roll and do lie flat for that 6-week period of time. Number 2, no driving for 6 weeks. And do not lift more than 5 pounds for 6 weeks. And how heavy is, what common household object is about 5 pounds? Gallon of milk. I know a lady that had back surgery, laminectomy, when her infant was like 9 months old. And that was disaster. Why? She couldn't pick him up, and what does a 9-month-old always want? Picked up. That kid learned to walk real fast. I mean, that kid was walking at 10 months. I go, whoa! Well, necessity is the mother of invention, So that kid really learned. Permanent restrictions. Laminectomy patients will never be allowed to lift objects by bending at the waist. How should they lift objects? Lift with the knees. Well, everybody should be that way, right? Should anybody do this? You should all do it with your knees. That way you get bilateral knee replacements instead of a laminectomy. Second thing, cervical lambs are not allowed to lift anything over their head. Nothing goes over your head with a cervical lamb for the rest of your life. So can a cervical lamb do this?
Yeah.
This? Yes.
Yeah.
That? No, not even with a feather. So they need step stools in their house. And then no off-trail biking, jerky amusement park rides, or horseback riding for obvious reasons. The percussion stuff. So that's laminectomy. But understand, this lecture on laminectomy can be used to get any spinal cord questions correct. Correct? Isn't that true? Because you're going to pay attention to what? Location. And that's where it's going to pay off. Okay, tomorrow for the last day. And I think, let me see, we covered 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We did 18 already, and we have 1, 2, 8 to go, right? Is it 8 to go? And we did probably 10 today. So we have less to do tomorrow than we did today. So we'll see you tomorrow. And we've not even been together for more than 24 hours. That's amazing. Anyway, I know. And that's why, but this is what the book says. So you have to go with what the book says, and this is book stuff. There is usually ileus on the book.
Oh God, I'm running.
Because coughing and bowels. The thoracic is always about coughing and bowels.
What's this?
Alright.
Okay.
Popping and bow.
Force test the Erickson's stages of development.
Yes, and that's
That was number two.
So,
Yep.
So tie this to this.
tie this to that. Yeah, it's sort of built on it, but not built on it. This is more built on cognitive ability, more Piaget, whereas because Erickson is psychosocial development, toys are a lot more cognitive.
Number B.
Your ability to play a game of toys is more
Alias
your
in the
cognitive
movie, which he
development
said
than your
means popping and
psychological
bow.
development.
So look at this. That's here and the blue book.
Yes, that blue book is so essential. I can't stress it enough. But that book is learning the stuff that only you can do. I can't learn it for you. You just have to put in the time to learn it. And I know a lot of people just go, but you know, that's the way it goes. Because if you put in the time, it'll pay off.
Okay, thank you.
And pneumonia, popping and bow, urinary and leg problems, and then pneumonia after cervical watch for pneumonia. Oh, but anyways, we could always recheck.
Yeah.
And we'll start on page 35, lab values. You have to know your lab values. But the good news is you don't have to know them all. Just certain ones that everybody else knows. There's kind of more bad news, and that is not only do you have to know lab values, but you have to know which lab values are more dangerous than what other lab values. So if you knew 10 lab values, you need to know which ones are high priority, which ones are middle priority, and which ones are low priority. Because they will ask you to prioritize people according to their lab values. Like they'll give you 4 different patients, a patient with a potassium of 7.4, potassium with a pH of 6.8, a person with a hemoglobin of 10, and a person with a BUN of 54, and they want to know who's your highest priority patient. That kind of thing. So it's not good enough just to know the values themselves. Because they will give you 4 people, all of them have abnormal lab values. All of them do. So what you have to do is then rank them, on who's highest, who's lowest priority. So what I want to do is teach you that, because I don't believe any school I know of teaches students how to prioritize lab values. They teach you the lab values. They teach you the numbers, the ranges, what's normal, what's abnormal. They teach you what high means, what low means. They teach you the significance of the test, but they don't teach you that a hemoglobin of 7 is a higher priority than a person with an INR of 3.4. Do you see what I'm saying? They don't get to that. Now, am I mistaken? Are some schools doing that? Are any schools doing that?
They pretty much use about potassium, but that's about it.
They just say potassium's bad. And that's probably on boards, that'd probably be the least you should know, at least that. But, I'm going to give you a scheme here. You see the legend at the top of the page where it says A, B, C, D? A means that it's not a priority. It's a low priority. It's not a big deal. Yes, it's abnormal. The lab is abnormal. But really, there's nothing you need to do about it. In fact, in real life, what I'm going to do is, let me back up. What I'm going to do is, for every lab value I give you, I'll tell you whether the abnormal is an A, a B, a C, or a D. I'll assign a priority letter to it. Are you understanding where we're headed with this? And when I tell you that a lab abnormality is a level A, what I'm trying to communicate to you is that yes, it is abnormal. And yes, it could mean there is the presence of disease. But in the scheme of things, this is really no big deal. In fact, you don't have to do anything about it. In other words, if a lab report came back and it's an A level, You could ignore it all night long and have the doctor discover it in the morning, and you wouldn't be in any trouble for having that happen. Do you understand what I'm saying? However, if I tell you it's a C level C, letter C, and you do nothing about it all night long, and the doctor finds out about it in the morning, you are in major trouble. So I'm trying to give you a feel for how important it is that you must report these or do something immediately. So an A is abnormal, yes, but you do nothing about it, it's no big deal. A letter B, it is abnormal and you need to be concerned, but there's nothing you need to do. You just kind of watch them closer. Have you had the experience where you had a lab value that was abnormal, but it really wasn't all that bad? So you didn't have to do anything, but that lab abnormality said to you, watch them closer, watch them closer. That's what I'm trying to tell you a B is. When I tell you that a lab value is a C, we've now crossed a line from low priority to high priority. When a lab reaches a C value, it is critical. You must do something about it. You can't just sit on that lab value and do nothing. If I tell you that a lab abnormality is a D, I'm trying to communicate to you that it is the highest priority that you can possibly have with a lab value. So what's the lowest priority?
A.
Followed by B. And then what are two high priorities? C. And the highest of all is D. Okay, just so everybody know where we're headed here. Okay, now let's start into this lecture. In the first column, there's the name and anything I want to tell you about it. In the middle column, you'll write the range, the normal range. And in the last column, we'll assign the A, the B, the C, or the D. Alrighty? Let's talk about creatinine. I told you 2 days ago that it is the best indicator of kidney or renal function. Now, in this case, I am talking about the serum creatinine, because they will not give you the values for a creatinine clearance, 24-hour creatinine clearance. They aren't going to test you on that. But they will test you on the serum creatinine. Now, the serum creatinine is 0.6 to 1.2, which is actually the same numbers as the lithium range. If you recall that from yesterday, the lithium and the creatinine are the same range. Okay, in the middle column, you have that. In the last column, an abnormal creatinine is just a level A. You would never prioritize a person with a high creatinine as your highest priority. Now, do they have kidney disease? If they have a high creatinine, yes. But are they going to die in the next 4 hours? No. The next morning, the doctor could come in and go, oh, his creatinine is high. He must have kidney disease, and that's fine. You're not going to be in any trouble for it. Probably the only time that I would ever make a high creatinine something that I would actually make a phone call to a doctor about is if they were going for a test that had a dye in it that next morning. Like, for example, if they're having a cardiac catheterization where they put the dye in, if the question tells you that they're to have a dye procedure in the morning, I might make a high creatinine something that I would report, but it wouldn't be in the next hour. It would just be sometime, like for example, if you got the high creatinine back at midnight, I wouldn't call the doctor till 5 or 6 in the morning at the earliest. I might wait till 7. I certainly wouldn't call him at 1 in the morning. But there are certain lab values you're going to see where you call them right away. So this would, even then, it wouldn't be a super high priority, but it would be higher than just a plain high creatinine. Does everybody understand that? Okay. The INR, the International Normalized Ratio, it monitors Coumadin therapy. It's like the PT. It's a variation of the prothrombin time. Its normal range should be 2 and 3, in the 2s and 3s. In other words, you want your INRs to be in the 2s and the 3s. Like 2.1, 3.8, that's what you want. In the last column, anything that's above 4, or 4 and above, is a C, which means it's high priority. You have to do something. This is not one you can ignore. You can ignore the creatinine, but you cannot ignore this one. An INR of 4.2 would be a higher priority than a creatinine of 30. Now, when I assign something a letter C, what do I say are the implications of that? It's critical and you have to what? Do something. Now, the question you should be asking is, well, what's the do that I should do? Well, whenever you get a situation where they want to know what are you going to do about something, there's a protocol you need to follow, an order, because this would be a click and drag. You always hold. That's the first thing you do. What do I mean by hold? If there's something that's causing a problem, stop it first. First. After you hold, then you assess. What would you assess? A whole, complete, head-to-toe physical exam, yes or no? No, a focused assessment. Focused on what? The area that the lab value is telling you there's some problem with. But do a focused assessment. Then you prepare, which means you prepare to give. Now, you don't always give, but you prepare to. And after you prepare, then you call. Meaning call physician, or call respiratory, or call whomever is appropriate. But before you call the physician, you always hold, assess, and prepare. Now, if we apply this to the INR of 4.7, let's say you get an INR of 4.7, and they want to know what are you going to do, in what order, and you have to click and drag. What would you click first?
Hold.
Hold what? Hold Coumadin. Hold all Coumadin. Then what would you do? Assess for what? Bleeding. Then you would vitamin K, prepare to give vitamin K, and then you would call your doctor. In that order. Now, sometimes there may be nothing to hold. Do you understand what I'm saying? There's nothing to hold. There's nothing causing a problem, so you jump immediately to what? Assess. And sometimes there may not be anything to prepare, so you jump to call. But you should intellectually go through that process with everything you do something about so that you're thorough, so that you don't miss a step. All right, potassium. Potassium, there's nothing I want to say about it in the first column, except that it's not really a good indicator of anything, but it is an indicator that something's wrong, but you don't know what. Its range is 3.5, and then flip it around 5.3. 3.5 to 5.3. Now for Hesse, it's 3.5 to 5.0. For Hesse, it's 3.5 to 5.0. But for boards, it's 3.5 to 5.3. Why? Why the difference? Boards is a nationalized, Hesse uses whatever Elsevier lab book says. Okay? So, to Hesse, a 5.1 potassium is an elevation. On boards, a 5.1 is not an elevation. Now, let's talk about the last column. A low potassium, meaning lower than 3.5, is a C. You have to do something. Okay, now let's go through our protocol. If your potassium is low, is there anything you have to hold? No. So what do? But what are you assessing? What's your focus? Heart. Assess heart. Prepare to administer vitamin K. Vitamin K. Potassium. I always do that. I always used to do that. Everybody ever do that? Vitamin K and potassium K? I screwed that up for like 10 years. Okay, and then I what? Call the doc. All right. What if it's between 5.4 and 5.9? That gets a C. So now you have to do something. Well, is it high or low? High. So what do you think we would first do? Hold all potassium. And that may mean ripping down the D5W with 20 of KCl. You know what I mean? Getting that torn down. Then you assess the heart. Then you... What? Now, Lasix does make you lose potassium, but we don't give Lasix for the purpose of losing potassium. Kxalate and D5W and regular insulin. Remember yesterday? Kxalate and D5W and regular insulin. And then you call your doc. However, in the last column, if the potassium is greater than or equal to 6, it's a D. It is deadly dangerous. This person could die soon, like in the next 2 minutes. So what do? You do everything we just said. You rip down the IV, you assess the heart, you prepare the D5W, regular insulin, and the Kxalate, and you call your doctor. You do all that what? Stat. So how many people have to be involved? You probably got one nurse ripping out the what? Potassium. You got somebody calling for an EKG coming. One nurse is preparing the D5W and regular insulin while the secretary's calling the doctor's stat. You see what I'm saying? And you stay with your patient. Got it? Because you can't leave the bedside of a D. You understand what I'm saying? Can you leave the bedside of a C? Do you even know what I'm talking about? D's and C's. Okay, got it. Okay. Can you leave the bedside of a C? Yeah. Can you leave the bedside of a D?
Nope.
No. So one of the things you're going to have to remember when you're answering these D questions is you stay at the bedside and you do what you can do at the bedside, but everybody else helps you do everything else. You don't run out and get the EKG and leave your patient by themselves with a potassium of 7. Okay? Now, I'm not saying you do this in real life. You should do it in real life, but I'm saying this is what the book wants you to do. And really, if you really did this, you wouldn't get in trouble. Your patient would be in good shape. Okay, the pH, 7.35, 7.45 is the range, which you told me the other day. In the last column, the only thing that matters is a pH in the 6s is a D. Now, I don't mean 7.6. I'm talking about 6 point something in the 6s. Now, you notice that do you notice with the creatinine, I didn't talk about a low creatinine. Did you notice that? And in an INR, I didn't talk about a low INR. And here I'm not talking about a high pH because those aren't that clinically significant and they're not usually tested at all. You see what I'm saying? These are the things that are tested over and over and over again. So rather than have you learn everything, let's focus on what's essential. Alrighty, pH in the 6s. So what do? Is there anything to hold? I can't think of anything. What would you assess? Now this is interesting. What do you think you'd assess? Somebody said respiration, somebody said pulse. There you go. Lump them together, check your vital signs. Because the pH is going in what direction? Down. And as the pH goes, so goes your patient. So the patient is going to be going what? Down and out. And you're checking, with a pH in the 6s, to be totally transparent and honest with you, you're doing the vitals to make sure they're still alive. I know that sounds ridiculous, but you really are. Because, usually when you have a 6, you're dead. So you're just making sure they're alive. And then is there anything to prepare? Not really. Used to be, years ago, because they were severely acidotic, we would prepare bicarbonate to give bicarb, but you don't do that anymore. You don't indiscriminately give bicarbonate like, if you've ever been taught that, no, you don't do that. You don't give bicarb anymore to acidotic patients because it confuses the whole issue. The key is to correct this acidosis. The only way you can correct it is to treat the underlying cause. And there is nothing a nurse can do to treat the underlying cause. The physician has to get here, determine the cause, and treat the cause. So, with a low pH, you have to get the physician in on the case faster than anything else we'll talk about today. So, that's why you just assess their vital signs and you call your doc. And you skip hold and you skip prepare. Now, why are you getting the vitals?
Make sure they're alive.
Because when you call the doc, what are they going to say? Is he alive? Is he breathing? What's his heart doing? So get a set of vitals. That's all you need. Set of vitals. Call the doc. And you stay.
With the patient.
So who gets the vitals? You do. Who calls the doc? Maybe some, put on the light or whatever, and however you communicate to your unit secretary, and have them call stat. Okay, BUN, blood urea nitrogen, BUN. It has a lot to do with nitrogen waste products in the blood. Its range is 8 to 25. 8 to 25. The way I remember that is BUN spells what English word? Bun. Buns, like hamburger buns, hot dog buns. When you buy hamburger buns or hot dog buns, how many are in the pack? 8. There's your 8. Buns, 8. 8 to 25. And if the BUN is elevated, it's no big deal. All you do is assess them for dehydration. Assess them for dehydration. By the way, a little hint. Good guessing strategy here. If they give you an elevated blood value and you have no clue what's going on, and they ask you, for what would you assess them? Dehydration is a great answer. Because when you dehydrate, what happens to all blood values? They go up because of concentration. So it's just a really good guess to say, when the BUN's up, I don't know what it is. Well, pick dehydration. Good answer. You may be wrong, but it was a good answer. Might not have made the top 10 surveyed, but it's not bad. I don't know why I had an extra L on the end of elevated, but Hemoglobin is the next one. It's 12 to 18. Now, I know it's 12 to 16 for women and 14 to 18 for men, but for humans, it's 12 to 18. And boards doesn't get into lab values versus men versus women, children versus adults, newborns versus. They could be on your test, but those are really hard questions, and you do not have to get those right. But if you don't know a normal adult hemoglobin, you're in trouble. If it's 8 to 11, if the hemoglobin is 8 to 11, it's a B. And you would assess them for what? Low hemoglobin. Anemia, a bleeding or malnutrition. If the hemoglobin, however, falls below an 8, it's a C, and you must do something. Okay, well, what are you going to do? You going to hold anything? Not that I know of. You're going to assess for bleeding. You're going to prepare to administer blood, and you're going to call the doctor. Now, LPNs, you would prepare, but you would call. Not on this, but on everything where we've said call doctor, you could substitute notify RN. Do you see what I'm saying? You could, wherever this could say hold, assess, prepare, notify RN. Alrighty? Bicarb. The bicarb is what? 2 plus 2 plus 2 equals 6, right? 22 to 26. And an abnormal bicarb is an A. We don't care. So what? You know, I've never, in 37 years of being a nurse, I have never been yelled at by anybody because I didn't tell them what somebody's bicarb was. It's just not a major issue. Okay, CO2, carbon dioxide. This you are getting from an arterial blood gas, by the way. The normal range is 35 to 45. It's the same as the pH, just dropping off the 7 point. Correct? In the last column, a CO2 that's high, but in the 50s, like 51, 57, 56, 59, those are C levels. That's a C, which means it's critical. You can't just sit on it. You got to do something about that. That's not good. Now, I want to say a disclaimer. I'm not talking about COPD clients here at all. That changes everything. This is for people without COPD. So what do you do? Well, is there anything to hold? A high CO2, anything to hold? I don't think so. What would you assess?
Respiration.
Respiratory status. Now, when it comes to prepare on this one, there is actually something you can do. There is actually something you can independently, as an LPN or an RN, do. What would that be? Okay, breathing in a bag actually recirculates the CO2, so we don't want that. That would be raising the CO2. What's that? Oxygen is used for low oxygen, not for high CO2.
Bagel down,
What's that?
look down like on your thumb, where you're, I read that if you actually put your thumb in your mouth and blow.
Oh yeah. Okay, like your Or they'll say the candle. This is a candle. Blow out the candle. That is called pursed lip breathing. Have you heard of that? This is what you're going to pick. Pursed lip breathing. Because with pursed lip breathing, you're prolonging the exhalation. And if you prolong exhaling, you're getting rid of CO2. Now, most of the time, that will correct the problem, so you never have to move to what? Call. How do you know it's going to correct the problem? They will breathe easier. Because when they're in the 50s, it's going to be dyspneic. They'll be dyspneic when their CO2's in the 50s. So that will solve that problem. However, what if the CO2 is in the 60s? That's a D. That's one of the criteria for making the diagnosis respiratory failure. Have you heard of respiratory failure? Well, how do you know someone's in respiratory failure? Well, one of the ways you know is the CO2 is 60 and above. Now, here again, we're not talking about COPDers. So this is a medical emergency. This is a super high priority patient. So you do not what? Leave the room. You stay with them. So is there anything to hold in this case? Nope. Assess their respiratory status. Now, pursed lip breathing isn't going to cut it. Now, I will probably do it with them just to decrease their anxiety and maybe take the edge off of it. But I'm going to have to prepare for what? Two things, because they're in respiratory failure. Intubate and ventilate. So you prepare to intubate and ventilate. And then who do you call? There's two people to call. Who do you call first? Respiratory therapy first. Call respiratory therapy first. Then call the physician. But you stay with your patient. Yes?
At that point, would you also call the emergency response team? Or does that come later?
Like a code?
Well, like a pre-code.
A pre-code? Yeah. On boards, they really don't have anything that's called an emergency response pre-code team. They don't. Certain hospitals have that, some don't. And because it's not a universal phenomenon across the nation in every hospital, they won't even go there. But I would say if I were you and I had one of those teams at my disposal in a hospital, yes, at this point I would, because this person's going to end up on a vent. And that's the best that's going to happen. You know, the worst could happen before. So, yeah. All right. Hematocrit. Hematocrit is 36 to 54. 36 to 54. Now, I don't remember that. That's why I had to think for a few seconds before I said it. I never remember that because that's a clumsy number, 3654. You know, it's just sloppy. Well, it's 3 times the hemoglobin. So whatever the hemoglobin is, multiply that by 3. And that's why I had to do the math in my head there for a second before I told you. So 12 times 3 is 36, and 18 times 3 is 54. So it's 36 to 54. Okay, an elevated hematocrit. An elevated hematocrit. It's abnormal, it's a B. An elevated hematocrit. What would you assess for? Dehydration. Good job. Dehydration. But it's no big deal. Okay, let's talk about the oxygen level, the PO2, the oxygen level. Here again, you're getting this from the arterial blood gas. This is not what you're getting when you put on the pulse ox on their finger or their earlobe. That is not the PO2. The PO2 is from the blood gas. Now the PO2 normally should be 78 to 100. 78 to 100 is the normal range. If it is low, but still in the 70s, like 70 to 77, that is a C, which means you have to do something. It's critical. So, is there anything to hold? No. You assess what? Respiratory. Now, there is something you can do, both LPNs and RNs, without a physician's order. And what is that? Give them oxygen, because their oxygen is low. So now you give them oxygen. And 9 times out of 10, what will happen? Will it correct it or not? It will correct it, and you will not have to call your physician. And how will you know it corrects it? Because you're not having a continuous arterial blood gas measurement. You'll know because the dyspnea goes away. And the restlessness and the anxiety and the tachycardia. By the way, just an interesting thing so I know everybody knows this, because they love to test this. When someone is hypoxic, which rate increases first? The respiratory rate or the heart rate? Heart rate. So when you go hypoxic, your heart rate will speed up first. Then, when the heart can no longer compensate for it, your respiratory rate goes up. A lot of people think, oh, hypoxic, your respiratory rate will go up first. No, it won't. Your heart rate goes up first. If you ever work coronary care, what are the 2 most common causes of episodic tachycardia in heart patients? Hypoxia and dehydration. So a coronary care nurse knows that when you get these episodic tachycardias, all you have to do is increase the IV rate and give them some oxygen, and it goes away, and you never have to call your doctor. I would have to say 90% of the time that I have episodic tachycardia in the coronary care unit when I worked night shift there for 10 years, was at Mercy Medical Center in Springfield, now called Springfield Regional whatever Mall. I never had to call doctors because I would just up the IV rate or give them oxygen, and the tachycardia would go away. You always could tell a new nurse who came into coronary care because they were calling doctors in the middle of the night for episodic tachycardia. And the doc would say, well, did you increase the IV rate? No. Did you give them oxygen? No. Well, do that and call me back if it doesn't work, And that, I'm saying it politely. Okay. Okay, well, what if it's low in the 60s, meaning 68, 69, 64, 63? That's a D. That's the other criteria for respiratory failure. So what are the two defining characteristics for respiratory failure? CO2 in the 60s and an O2 in the 60s. When they're both in the 60s, that's when you need to intubate and ventilate them. So if it's in the 60s, there's nothing to hold. You assess the respiratory status. You prepare to intubate and ventilate. You call respiratory therapy, and you call the doctor. Now, you can put oxygen on them during that time. It's not going to solve the problem, but it's going to make them a little more calm. So if I had a click and drag on that one, where would I put the oxygen? I'd probably do this. I'd probably hold. I wouldn't hold anything. I'd assess. There's nothing to hold. I'd probably throw on the O2 just to make them what? Comfortable. Then I'd assess them, and then I'd prepare to intubate and ventilate, call respiratory therapy, and call the doctor. Yeah.
That kind of confuses me because I was always taught, I guess, to always assess first, and you're safe. In any question,
No, you're not. That's a gross oversimplification.
Okay.
She said that she was taught that in an order question, you always assess before you do. And that's true 80% of the time. 20% of the time it's wrong because there's something you need to hold before you assess. For example, you're giving a blood transfusion and somebody complains of itching and you see hives. What do? Stop the blood, then you do your assessment.
What about though in this situation? Because I would have assessed my patient first, then put the oxygen on that.
That would probably, I don't think, just in my impression, I think if you ask 50 nurses, you'd have half and half on that. And so I can't conceive that they would write that question on boards because it would be such an interpretive thing. Subjective kind of thing. But if the INR is 5, every nurse says, I'm going to stop the Coumadin and then I'm going to assess. That they would all say that. Mm-hmm. And if the potassium's 6, they'd say, I'd turn off the IV and then assess their heart.
Okay, that makes sense.
So yeah, it's going to be, there are certain things where I always tell people this. Assess before you do. Unless delaying doing puts your patient at higher risk. And if you would assess for signs of blood transfusion reaction, if you delayed stopping the blood to do an assessment of are they having a reaction, you would be putting the person at increased risk. So therefore you do before you assess. So what's the rule, everybody? Assess before you do, unless delaying doing in order to assess puts the patient at risk. For example, a patient pulls out their arterial line They are bleeding in bright red spurts from their radial artery. What's the first thing you do? Assess their vital signs. Apply pressure. Okay? Well, one's assess, one's do, right? Well, if you delay putting pressure in order to take a set of vitals, are you increasing the risk to the patient? Yes. Therefore, do will precede assess. And that's an obvious one, but I'm trying to illustrate the principle. Are you seeing that?
Yeah.
Okay. Good question. Because that's one that everybody's taught. How many were taught? Assess before you do. Assess before you do. But you have to understand, whenever you use a rule like that, you have to understand that there's always an exception, and what's the exception? Yes?
Not Carmel group always had a question on ATI that would always catch us up, and it was something about with respiratory situation, which do you do first? And it had head of the bed,
Yes.
and oxygen, and
Yeah.
talking about assessing and calling the doctor. et
Yeah.
cetera.
The thing is if I was between somebody's having dyspnea, acute dyspnea, one was elevate the head of the bed, the other was put on oxygen, the other was call the doctor, and the others do a respiratory assessment. What would I do? I would elevate the head of the bed first. Alrighty? Because if I do a respiratory assessment with him lying flat, I'm getting data that's not going to be helpful. He's not going to cooperate with me. I'm not going to get good data. I'm not going to get full. So I'm going to elevate the head of the bed first. I always like to do, if I'm between two do's, I like to position first. You know, if I'm between two do's and one's a position and one's another action, I find that the position usually wins over the other action. How many have found that out, sort of seen that? So I would probably elevate the head of the bed. I would put the oxygen on. I would do an assessment, and then I would call the physician. Now, what did ATI say, I wonder? Is that what ATI said? Mm-hmm. Because I almost always position first. When I'm between two do's, I always position first. And see, my rule there would be, if somebody's in significant dyspnea and hypoxia, would delaying putting their head up and delaying giving them oxygen while I did a respiratory assessment put them in greater risk? And the answer is yes, you would be. You see, so then I would precede the assess with the do's. Do you see that? Yeah, question.
So if you rank the head of bed first, what you do best is give them open.
Bingo. You're smart. Good job. Did you hear what she said? She said, but what if it's not a first question? What if it's a best? And you're between oxygen and raised head of bed. Well, in a best question, and I'm really glad. Are you here for a refresher, or is this the first time you've taken this class? First time? Good job. Because if you had to do one, raise her head without giving her oxygen, or keep her flat with oxygen, she really will benefit better from the oxygen lying flat than she will up with no O2. So best would be O2. First would be raise head of bed. Is everybody seeing that? Good call. Okay. The O2 sat, the oxygen sat should be 93 to 100. Anything less than 93 is a C. Critical. There's nothing to hold. You assess them. You throw on the O2. Now you could, I don't think with an SaO2, unless they're in real danger, a low SaO2 is not going to, like an 88. There's no reason to throw on the O2 right away. You know what I'm saying? I don't, there's no big deal there. In fact, I can't even believe I'm telling you that an SaO2 below 93 is that bad. Because I'm happy with SaO2s of 88 and above. If you think that you're going to run around calling doctors in the middle of the night for SaO2s of 91, you're not going to last long. But on HESI particular, and on boards, if it's a 92 SaO2, they're in bad shape. And I'm telling you, that's not real life. But that's the book. Do you got me? Because HESI has a question on there where it says, they give you 4 patients and want to know who's your highest priority. And I remember taking it, and letter A was a patient with a 91 SaO2. And I went, oh, that's fine, you know. And then I went to B, and they were okay. And I went to C, and they were fine. And I went to D, and they were good too. And I thought, oh my goodness, they're all fine. And I thought, wait a minute. 90, it's not 93, it's 91. So that's the one that's in bad shape. So I picked them, I got it right. So you're just going to have to go with that, all right? Now, anybody ever want to work peds? In pediatrics, you better freak out when it's below 95. Okay, because little kids don't desaturate without... Older people, we desaturate all the time. You know, it's just what we do. But little kids don't desaturate. They usually won't go to COPD because then that anything could be... There's no... With COPDers, they're going to have abnormal blood gases. But there's no pattern to tell you what it's going to be and how much of one thing means what. Do you see what I'm saying? Like they can't say, well, you know, for respiratory failure for a COPDer, it's not 60 and 60, it's 70 and 50. There are no parameters. Every COPD their blood gases are individually judged on their level of functioning at that blood gas. So if you have a COPDer with a CO2 of 59, which it should never be, and a O2 of 64, which is horrible, but they're functioning okay, then that's their baseline. Do you see what I'm saying? And the hypercarbia is no issue because they don't have a hypercarbic drive to breathe. They have a hypoxic drive to breathe, so it doesn't even matter. So that's the issue. With a little hypoxia is good for a COPD because it keeps them breathing. That's why you don't want to give a lot of O2 to a COPD or they'll stop breathing on you. So yeah, I don't think that they could even ask a question that would be fair, other than the fact to know that COPDers normally run high on the CO2, low on the O2. So I guess my answer to you would be, if they gave me 4 patients and they told me one was a COPDer with a CO2 of 55 and an O2 of 71, even those are letter C's for you and I would not make them a high priority. Okay. BNP. Oh, by the way, when is your SaO2 invalid? What invalidates your finger probe SaO2 reading?
Anemia.
What's that?
Anemia.
Anemia falsely elevates it. So if somebody's anemic, they're going to look a lot better than they actually are. So if you have an anemic patient, your SaO2 is not helpful. You need to look at other indicators of oxygenation. The other thing that invalidates it is if they've had a dye procedure in the last 48 hours. Why? What does the dye do to blood? Color it. And what does that read? Color. So you're going to have falsely elevated SaO2s with anemia and after dye procedures. So in both cases, when you get your SaO2, you're going to think the patient is what? Better off than they actually are, which is actually pretty dangerous. Okay, BNP, which is the brain natriuretic peptide. Don't worry about that. It's the best indicator of congestive heart failure. It should be under 100. An elevated BNP is a B, which just means you've got congestive heart failure, but you're not going to die. You don't need to call the doctor in the middle of the night. There's nothing you have to do. Just watch them for CHF. See, it sounds kind of funny that a heart value is not a high priority, but this is a heart value because it's indicating a chronic condition. Do you understand why it's not high priority? Because it indicates a chronic condition, not an acute one. Sodium. Sodium is 135 to 145. If it's abnormal, it's a B, which means you assess. If the sodium is high, you assess for dehydration. If the sodium is low, you assess for overload. Remember hypernatremia, hyponatremia. The one with the E is dehydration. The one with the O is overload. However, if the question tells you the sodium is abnormal and there is a change in LOC, the priority of the patient shoots up to a level C. And basically, it's a safety issue at that point. It's safety. Which brings us to the last 3 lab values. Yay. You see why I didn't want to do this yesterday at 3:30? White blood cells. There are 3 white counts you must know. 3 white counts you must know. The first one is the total white blood cell count, which is 5,000 to 11,000. The other 2 are the ANC, the absolute neutrophil count, which needs to be above 500. There's no range here, it's just a threshold limit. You must have more than 500 ANCs per cubic millimeter. And the last one is the CD4 count, and it needs to be above 200. Because remember, when your CD4 falls below 200, what do you have? Not HIV, you got AIDS now. So the defining line between HIV disease and AIDS is the 200 CD4. If you've got 201, you have HIV disease. If you've got 199, you have AIDS. So all of those are low white counts. And all of those are a letter C. All of those below those levels. An ANC below 500. A white blood count below 5,000. And a CD4 count below 200. All of those are level Cs. They all are. And because of that, there's nothing to hold. You assess for signs of infection. And instead of preparing, what you do is you place them on these neutropenic precautions that are in your last column. And it would be good for you to know those, because they do test what's on the neutropenic precautions. The one that it's amazing how you could be a nurse for decades and certain facts you just never learned. It was like 10 years ago, after I've been a nurse for 20 some years, that I learned the 9th one. I think it's the 9th one down. Don't drink water that has been standing longer than 15 minutes. I didn't realize on these neutropenic precautions they are not allowed to have a water pitcher. If they want water, you bring them fresh water. And the water isn't allowed to stand. In fact, the water bottles, if they're unopened, I think they're good for 4 hours. If they're open, they're good for an hour. Yes?
I have my leadership on oncology, hematology, and insurance. And I had patients who were getting the NT transplants.
Yes,
And
bone
I had,
marrow transplants.
I had ANC patients with literally 2. Not
With a
200,
two.
With
With a 2.
And the neutropenic precautions they had to do, like this patient, the nurse, when she had this patient, you could only have 1 patient because
Exactly.
the precautions were so
Rigorous.
timely and rigorous. And
What did they use for the water bottles? What did they use?
you weren't allowed to have a water bottle open unless you drank it right away, and they had a special refrigerator that we were able to go. Like, you couldn't just get them regular water. We had to go to the BMT refrigerator, which was always locked. We'd unlock it, get it out, bring it to them, watch them drink it, throw it out. Right
Throw it out. So it wasn't even an hour. Okay.
I think you'd have to 20, 30 minutes to let the patient drink it, you know. But there were certain, and then we had to clean the room every, I think it was either every 4 or every 6. We had to clean it down with this really special little room. I mean, the point is they can really get more obsessive than this. A lot more. So this is sort of like the least you would do. And this is see, with bone marrow transplants, you got to be really, really careful because they're really dangerous. Because what did we do? What did we do to them? We irradiated total body irradiation. We irradiated all of their protection. They have none. 0. I'm surprised she had 2. I've seen some with practically none.
Okay, so neutropenics are really important. Okay, platelets. Platelets, I'm not going to give you a normal range because I've looked in 5 different books and they don't even overlap. Nobody knows what a normal platelet count is, I don't think. But the key is, what are the trigger values for thrombocytopenic precautions or bleeding precautions? And that is in your last column. A platelet count below 90,000 is a C. You need to put them on these bleeding precautions. And if the platelet falls below 40,000, now, you'll hear people say, he has 40 platelets or 35 platelets. They don't mean 35. They mean 35,000. So if they say his platelet count is 3, what do they mean? 3,000. They don't mean 30. Okay, now the ANC means what it says. But this is usually in thousands. And then red blood cells are 4 to 6 million. Red blood cells are 4 to 6 million, and an abnormal red count is just a B. It's no big deal. Okay, now, that's a lot of info. Here's what I want you to do with it. Memorize the 5 Ds. Why should you memorize the 5 Ds? Because those are the really high ones that if you don't know, you're unsafe, and you don't want to show that on this test. So what are the 5 Ds? pH in the 6s. Not bicarb. Okay, but there's one before that. Potassium in the... So a potassium in the 6s, a pH in the 6s. Got that? Now what is the next one? CO2 in the 6Ds and an O2 in the 6Ds. So a pH or a potassium in the 6s, or a CO2 or an O2 in the 6Ds. So what pattern are you seeing already? 6s and 6Ds you don't like. And then what's the 5th one? Platelet count of less than 40,000. Those are your highest priority people. Nobody will beat them. And boards will not put those people against each other, because it's not fair. Okay, now, what I would then do is learn all the C's. There's probably about a good 8 to 10 of them. Then I would not remember the priority on any of the others. Why? Because that way, if you don't remember them, they are what? Priority? Low. Do you see what I'm saying? So just remember the high ones and everything else is low. So remember your D's, which I think are easy, your 6s and 6Ds in the 40,000. And then your C's, and probably what to do for them, and then you're good to go. And you really will be so much better prepared for the questions than anybody else sitting there. You know? So, because everybody else is just going to what? Guess. And say, well, potassium. And then if it's not potassium, they're dead in the water. Okay, let's turn to something near the back of the book. I want to get it done earlier because it's just a horrible lecture to do late in the day.